Is he ready?
He'll have heard that, Chair, and I'm sure he'll give me a little message as soon as we're live, and then you're good to go. We're now live, Chair. Over to yourself.
Thank you very much. Well, good morning, everybody. Welcome. Hope everybody's well. And above all, keep smiling. There's not much else we can do, so keep smiling. Just to remind you, when we get started, to make sure you're muted and turn the camera off unless you wish to speak. That way we cut down all the background interference. Going on to the agenda, we item 1, apologies. We do have an apology from Kate Rolfe, who is replaced by Clive there. So welcome, Clive. Good to see you. Do we have any disclosures of pecuniary or non-pecuniary interests? I do not see anybody declaring any. Well, I've got one hand up there from Barry Longdon. Yes, Barry.
Morning, Chair. Thank you very much. My interests have not been recorded with the County Council at the moment, so I don't know if you want me to go through those or just raise it at the time if anything comes up. I don't think there's anything on the agenda that's going to come up, so...
No, I think we'll accept that, Barry. Thank you.
Okay, thank you.
Okay, I can't see any others. Going on to item 1.3, Chair's announcement. Barry's just been on. Barry Longdon's just been on. Welcome, Barry. He's the new representative for Nuneaton and Bedworth, and I think I'm right in saying he is the chair of the external overview and scrutiny panel of the Nuneaton and Bedworth Borough Council. So welcome to you, Barry.
Thank you.
I have one other item to convey to members. If you remember, we agreed to have a task and finish group on health and inequalities, health inequalities. I have received information. There's been a bit of dialogue that's been going on in the background, emails passing from one and all, well, not from me, but from other councillors, and it's the leader's decision that because of the current emergency and the work that is having to be carried out by officers, the demand, etc., that the task and finish group should be delayed until the situation improves. So the task and finish group will be delayed further. Keith, I see your hand up, Keith.
Yeah, thank you, Chair. I think we need to be careful it's not touched into the long grass forever, because the situation improves is a vague term. I think there was a lack of capacity to amongst officers, so I think it's when we get capacity to do it, not when the COVID outbreak is fully over, because otherwise we won't be solving the things in the tail of the pandemic.
I can assure you, Keith, that it will not be kicked into the long grass. We shall have this as an ongoing item for future discussion at our spokespersons meeting. So it will be something that's brought up on a regular basis. I see Helen, you've got your hand up, Helen.
Thanks, Chair. Yeah, just wondering what sort of timeline we're talking about now then.
I personally have no indication of that, but I think it is something that we shall be discussing at our next spokespersons meetings. I don't think we can just have it delayed and delayed. I think we need to see some positive outcome, an expectation that it will be going, it will be going ahead. In my opinion, sooner rather than too late. But I'm sure that we will keep an eye on it at the spokespersons meetings.
Okay, thanks.
I can't see any other hands up. If I miss any, Paul, you better give me a nod. Okay. Minutes of the previous meeting held on the 18th of December, 18th of November last year. Is it your wish that they be approved as a true record of that meeting? Yeah. I don't see anybody disagreeing. Thank you, Joe. Okay, thank you very much. Our next item is public speaking, which we do have two questions. Now, the item 1 there, 2.1, is a question that has been we received from Councillor Jackie Chambers. Unfortunately, I've received notification that Jackie is unable to be with us this morning. She's had to take her husband to hospital. Do we have a response from for that? I mean, we shall obviously have to give Jackie a written response, but is Becky with us? Becky Hale? Paul.
Thank you, Chair. I've just looked down the list of officers present, and I do know that Nigel Minns was hoping to give you a response on that. Nigel's also running 2 meetings at once today and is in and out. I don't think Nigel's in the meeting at the moment. Okay. I have in front of me, Chair, a response which I can circulate straight after the meeting, which addresses Part B of that. And I think there's an aspect which relates more to the clinical commissioning groups. So again, was going to take that as an action, Chair, and forward that to the CCG's post-meeting, if I may.
Okay, I'm happy with that. Everybody happy with that response? We'll get that response written to Jackie and a copy to all members of this committee. Thank you. Our next question is from Councillor Helen Atkins on behalf of the Keep Our NHS Public Group. Helen, do you wish to? Are you there, Helen? Do you wish to speak on it?
I haven't got it in front of me, Chair. I assume that everybody would have had it before and read it. Okay. So if we've got a response, then I'm happy just to hear the response, if that's all right.
Okay, thank you. Sade, do you wish to comment at this stage?
Yes, thank you, Chair. So I have prepared a written response, which I've sent round yesterday to Paul, so hopefully that should be shared. The question was asking, it was on the basis of a BMJ article that's just been published that found that a total of 114 local authorities are currently rolling out lateral flow testing, and of these, nearly half did not explain the limitations of the test or make it clear that people needed to continue following the restrictions or safety measures even if they tested negative. My response is that Warwickshire County Council makes this clear, and I have provided screenshots from our Eventbrite booking page when people want to book the lateral flow test. People are asked to go to our dedicated web page, which is on the Warwickshire County Council website, that provides information on what happens after you receive a positive test result and what happens after you receive a negative test result. The information states clearly that if you test negative, you don't need to isolate, but you do need to continue to follow the guidelines of hands, face, space, and keep your contacts to a minimum. It also states that you should ensure that you get tested weekly at one of our 6 test centres, and urges people to continue to be vigilant and follow national guidelines. Also tells them to book a test via the gov.uk or ring 119 if they develop any symptoms. So I have shared screenshots from the Eventbrite booking page, from the Warwickshire County Council webpage, and the information that people get after the results comes back from NHS Test and Trace.
Thank you very much, Sade. Les, did you wish to comment?
Thank you, Chair. Yeah, fully support what Sade says. I mean, the lateral flow testing and other testing is part of our armoury of keeping the excellent position we're in. And anybody that's looked at the figures this morning, know we're down again and below the national average. And that's a tribute to Sade and her team that have stuck with the lateral flow testing. I mean, I personally have been attacked by a member of the Save the NHS group that we're doing it all wrong. I do not believe that. This is a vital tool in our armoury and is keeping Warwickshire and its residents safe. So I fully support Sade in the action she's taken and the response she's given. But Warwickshire is in a very good place, and also we are regarded in the work we've done on this, and Sade and her team, as a national exemplar, and we should remember that. Thank you, Chair.
Thank you. Pam, you wish to, Councillor Pam?
Yes, if I may add to that, I do actually go to the lateral flow clinic in Pound Lane on a regular basis. It's excellent. The volunteers and staff there are very knowledgeable about what should be done and what shouldn't be done. And I can assure everybody they are informing people that you should still keep to social distancing and all the safeguarding as well. So excellent facility, and my thanks go to all the people that are involved in it. Brilliant.
Thank you.
Thank you.
Helen, did you want to come back?
Yeah, thank you, Sade, for that response. I will pass it on to Keep NHS Public, and I too have been to Pound Lane, had a lateral flow test, and it is being run very well. But I will pass your comments on. So thanks ever so much.
Okay, thank you, Helen. I should say that as Pam goes to the Pound Lane, that means I go too. Okay, thank you for that, Sade and Helen. That response, Helen, you'll get a copy in writing as well.
Great, thank you.
Okay. Our next item is questions to portfolio holders. We do have our portfolio holder, Les Caborn, here. So do we have any questions that any member wishes to put to him? Don't all rush at once.
Thanks, Chair.
Okay, no, there doesn't. Oh, hold on. No, Helen, thank you.
Yeah, I just wanted to pick up this issue about the task and finish group. I mean, I'd read Sade's draft report on the region and how things are going, and there are most of the indicators we are beyond the national average, and it is concerning, and that is across Warwickshire. So I think there is a real need to have this task and finish group. I don't want it to see it pushed into the long grass, and I know officers are stretched at the moment, but I do think it's important. We've been talking about it for a long time now. Thank you, Chair. That was just a comment, really. Thank you.
Well, I will respond. I've no intention of pushing it into the long grass. I followed the outcome, as you know, in the email exchange with the action of the joint committee, and certainly when we first I first took this to cabinet, Sade said at that time that this would be a 2 years to get all this information in, and actually the scope has widened because it's not just about health; it's far more wider than that. So I'm very keen that we do this. Very keen we get it on track as soon as possible. But certainly until pressure eases off the department a bit, we can't do, because as long as the testing that the teams that are doing the infection management are also doing all our supermarkets across the county in conjunction with the borough and district. Environmental health, and that's why we're not at the point as on the Midlands News last night with parts of the Midlands, going to serve orders on supermarkets. That sort of thing we're not doing. We are out there on the ground doing, and as soon as we get a bit of pace back from some of that work, then yes, I should be keen that we carry on with the vein work and the inequalities, because it's a vital part of our recovery. So I've no intention of slowing it down, but I'm trying to be realistic and supporting our staff.
Okay, thank you, Les. Margaret.
Thanks very much, Chairman. The vaccination programme in North Warwickshire has gone really well. I mean, it's fantastic. There's just a couple of issues. I would like to know what we do. We've got 1 or 2 people who are housebound who have been missed in their 80s and 90s. And I just wondered what the process was, because I've had a couple contact me and I'm not quite sure. I have spoken to Steve Maxey, but is there a process that we should be using if there's the odd one that we pick up?
Yes, it's as has been said nationally, they need to contact their doctor or somebody for them and say they've been missed, please, and if they need housebound support, somebody to come to them, then that will be arranged. So the call out is now for anybody that's been missed, please contact.
Yeah, so they have contacted their GPs, but there seems to be some confusion as to whose responsibility it is to go out. I'm not quite sure why there's this confusion.
Can I ask Sade to give you the detail on that rather than me?
That'd be great, yeah.
Through you, Chair.
Yeah, fine, thank you.
Having spoken to Ali Cartwright last week, she did assure me that vaccination of the housebound has started, and I think Ali's on the call, so she might. I've just seen that she's on the call, so she might be able to provide more information. But I do know that has started, so I'll leave it to Ali to give you more detail.
And Sarah's on the call, Chair, so she could help as well.
Thank you. Okay, Pam Redford.
Apologies, Chairman. My automatic hand doesn't appear to be working. Waving. I'd like to ask Councillor Caborn, in the nursing homes, care homes, are we keeping up to speed with the? There is a difficulty with some people having the vaccination, care workers. Are we up to speed with trying to encourage them to have this vaccine? What are we doing? Can you explain? And are we, what percentage of our care home staff are not accepting the vaccine?
That I don't know, but Sade and I are looking into it. But some of this information, whether Ali can help on that as well, is getting the information to us. There are some difficulties in free sharing of information, and Sade and myself are very keen to get that resolved. Unfortunately, we can't make any staff or any of our domiciliary care staff have the vaccine. We are doing all we can through publicity and through social care to encourage as many as we can. But again, the care homes are independent businesses. I'm sure they want it all. And of course, they have shift people coming in and out, and they also have workers in groups that move about. So it is a very different, but we are very keen to get everybody and residents as fast as possible vaccinated. But obviously, if we have a care home with an outbreak, we cannot go into it till some of the outbreak is before we vaccinate. So there are some delays where we have an outbreak, but they are going down and are fewer. So I'll let the other officers respond with detail, if I may, Chair.
Yes, fine, thank you.
Thank you.
Would you like me to respond on the vaccination questions?
Yes, please.
So the housebound, Councillor Bell, are being done as per the age cohort. So we have done like the over 80s, over 75s, etc. But the process is, if any have been missed, Councillor Caborn was right. It is the request for anybody over the age of 70, if we have missed any housebound patients, to contact their GP. There is 2 ways that patients can get housebound vaccinations. Some GPs are doing them themselves, and some are being done by a housebound team. But either way, if the patient contacts their GP, they will be passed on to the appropriate team that will be will go out and vaccinate that patient. There is obviously that we do have younger housebound patients who will come through the process as per the age bands, but yeah, there are, we will still pick up any housebounds if they contact their GP. And then the answer to the question about health and social care workers, more widely across the region, we have vaccinated 89% of health and social care workers. Obviously, that does vary across each individual healthcare or social care worker group. The care home staff current vaccination levels are between 62% and 71% at present, depending on different parts. And we are working hard. There's a lot of work ongoing about increasing those vaccination rates with myth-busting sessions, additional sessions being held. All health and social care staff can now access at any point the vaccination centre and things like that. So we're working hard to increase those uptake rates. But like Councillor Cabourn said, we can't force people to have the vaccination. What we can do is try and give them as much information as possible and to support them to make that decision.
Thank you, Alison. Dave Parsons.
Thank you, Chair. I mean, first of all, I'd really like to congratulate everybody involved in the efforts that are going on in Warwickshire at the moment. I think things are being done extremely well, and I mean, I have to say my own local practice in Polesworth has been absolutely exemplary in this. And yes, we are chasing up the odd housebound individual, and that's there, but it really has been great work. But one of the things that concerns me is that the old nuggets don't actually disappear, right? And obviously they do get sort of masked a little bit by COVID, and it's really a plea to Les, I think, and Sade in that sense. We've still got the age gap in terms of life expectancy north to south, as it were, and what I'm really looking for is what we might do to assess the impact of COVID on that as we hopefully come out of the COVID crisis. It may be that it doesn't have an impact, but my gut feeling is that it will, and I think we should perhaps be looking at how we could respond to that.
Yeah, take that on board. It is part of the recovery, and where we see after COVID, there's things like that are going to become more apparent as we come out, and also it's as I think we all agree, normal as we knew it has gone. Normal was where we started the COVID, not where we finish it, and it's part of picking all that up as we go. A, in the authorities' recovery, and B, as we look at the work within public health going forward, and priorities could change. It's things like the infection management teams we've got stood up. How long do we keep those stood up? When we gave those a life of 18 months when we started. I think I'm right, Sade. Will they need to be longer? There's that sort of thing. We're always thinking about, but we're not at the point yet to say that is the way we go. But yes, it is on the radar, and it's certainly part of the recovery for the whole authority, because there are certain people, as we're all well aware, in a way, bottom of the job pile that sort of lost their jobs quite early on because that were there. We've got to pick all that up as we move forward and see where the residual effects lie across health, but again, it's the 5 determinants of health as well that we've got to pick up, which is why a lot of the things like healthy living and that we're launching, the money we put in the budget into mental health. There's that sort of work we can do now, but there will still be some residual to pick up a bit further down the line, Dave. Yeah, totally aware of that. Agree with you.
Thank you for that, Les, and that's exactly what I wanted to hear. That's great. Thank you very much. Thank you.
Thank you, David. Keith.
Thank you, Chair. Just a couple of questions for Les. First, the number of people who are not having jabs in our care sectors, various health professions and care, are we actually surveying them? Because obviously we've got this reasonably large cohort, but some of them may have had COVID and think they don't need it. Some of them may think they could be pregnant and think it's not. Yeah. Are we doing a survey of these refusers? Because obviously it's hard to force people to have the jab, but if we understood the reason they're not having a jab, it might give us some better way of dealing with it. And for example, the people who've already had COVID, if they need a jab as a top-up of some point rather than 2 jabs, without knowing what's in that cluster, it's hard to know what to do. My second question is, I know the NHS England is not allowing the release of vaccination data yet at district level or finer. Hopefully that will change. I don't know if Les has got an indication of when we get that breakdown, because obviously in talking about inequalities, if parts of Bedworth or Rugby or wherever are particularly not taking up the vaccine, that's very useful information for us to work on the equalities issue. And it may be a problem in the population, or it may be a problem in the local GPs or the, who knows. But without having some granularity in the non-vaccination numbers, we don't have a way of working out what to do about it. Thank you, Chair.
Yeah, just on the staff one, we're doing a tremendous amount of specialist and targeted communications with Jane Sermon and Sade working together across all our BAME communities. And of course, that picked up many of our social care workers. So there are a lot of messages out there, and our adult social care staff are that are out there, and they are our ambassadors in a way, because that's where the touch point comes between our domiciliary care workers, our rehab staff and people like that. So that's where our touch point comes, and they are all out there and encouraging. But as soon as we can get some keep on a track of the figures, and I'm happy to let people know when available. But I'll ask Sade or Ali to comment on your second point, please.
Sade.
Yes, so the issue of vaccination data has been raised at various different meetings, national meetings repeatedly, and the need to share that data with the public, with elected members as well. We have just been given access to the NHS data, which is hosted on a platform called Foundry, and I've only just had access yesterday. So the DSPHs are just starting to have access. And this morning we've been asked to nominate 2 members of our team who would also have access to this data. So once we start to make sense of the data, there is, I think, a movement now, a consensus that we will start to share that data. I know that Birmingham have decided that they will start to share data confidentially. So we might be able to have those sort of conversations internally in the next couple of days, and then hopefully we'll be able to share that data with yourselves. But the point is, the data has just been given to us. We've only just got access, and we need to drill it down and hopefully present in a form that is easily understandable. I can tell us where the differences in uptake are, and hopefully support any work that we need to do to improve uptake in those wards or localities.
Thank you. Alison, did you want to come in on this? Thank you.
Yes, please. So there are we currently have 2 sets of data at the moment. So the NHS data, as Sade has just described, is on the Foundry system. And I'm pleased, Sade, you've just confirmed that you've got access to that. But there is also, you do have access to public health data that goes down to ward level, don't you, that has the inequality data in it. And I know that you and your teams and my teams are working together to understand that inequality data and variations in uptake rates in specific areas. And then what we're trying to do with that data is trying to get any additional vaccine coverage to cover those areas alongside a much wider programme of working with, it's a whole programme, isn't it? Working with multi-faith leaders, other professionally specific groups and things like that, and that work is ongoing. So while we can't currently share that data, which we hope will change, please rest assured that we are we have access to that data, and we are working on improving those uptake rates.
Thank you very much. Thank you. Keith, did you want to come back at all?
Just a quick to say that's marvellous. And one thing I'd like Sade and the team to just have a quick look at is the vaccination rate by GP surgery, because as Dave Parsons says, some surgeries have been absolutely marvellous. And obviously we want the, I think it's a Japanese frontrunner scheme, isn't it, where you look at the ones that are absolutely marvellous and then you ask, yeah, what are they doing differently to the others? Thank you.
Yeah.
Okay. I've got one more. Parminder.
Morning all. Chair, it's not a question, it's just really a shout out that I think the vaccination teams in our area have been absolutely brilliant, ought to be congratulated. My wife is housebound, so very early on we let the GP know that she's housebound, and last week somebody came from GP surgery, called and came and did a vaccination. They were absolutely fantastic. So no issues there. As far as the BAME community goes, locally, predominantly the BAME community is from Punjab or Sikh background, and I've been in touch with many of those, and all of those actually have participated in that. And in fact, when some of them when I ring, they say, "Well, I haven't had a call yet. When are they going to ring me?" So I don't think there's any issues there either. So congratulations to the team. It's really working well in our area. So that ought to be probably replicated elsewhere. Thank you very much.
Thank you, Parminder, and can I thank you for your help in this, because it really is appreciated. Thank you.
Thank you.
Okay, I don't see any more hands up. Could I remind? I've still got 3 hands up, but you've already spoken. So Parminder, Sade, and Alison, if you could just remove your hands from the screen, please. Thank you. Okay, now item 4 on the agenda. Members will remember that this is a new item which we agreed that we would be collating and submit a list of questions received from you and circulated to NHS organisations and members and providers. First one up is David Eltringham. Are you there, David?
Good morning, Councillor Redford and
Good morning, David. Thank you very much for coming.
That's no problem. So in discussion with Paul and preparation for this item, 2 headlines from the George Eliot Hospital that we thought it would be useful to share. So the first is the number of patients in hospital has halved over the last 4 weeks. That's the number of patients in hospital with COVID-19. However, the hospital does remain very busy. Those who remain in hospital are very sick, and we are continuing to operate with twice our usual intensive care capacity open as a result of that. As you can imagine, our staff are quite tired, having been working on this for some considerable time now, and we're very focused on looking after their well-being. The hospital therefore does continue to run under pressure, and in this context, important to just take the opportunity to remind colleagues and members of the public of the importance of sticking to lockdown rules and following the hands, face, space guidance, and we really can't underestimate the importance of that in controlling the workload on the hospital and the NHS at large. And then secondly, delighted to report that we've been successful in securing funding to build 2 new operating theatres on the George Eliot site, which will become part of our Captain Sir Tom Moore surgical unit, which we opened last year. We opened the unit with a temporary single operating theatre, which is basically off the back of a lorry. This funding will allow us to build 2 permanent operating theatres onto the Captain Sir Tom Moore unit. The theatres have been designed in partnership with our surgeons and will be state-of-the-art, and we expect to start building those units early in March, with the expectation they'll be online late in the summer or early autumn. And certainly before we get into next winter, and that is really helpful in terms of being able to increase our protected green pathway capacity as we get ready to recover from this wave of the COVID-19 pandemic. So that's really good news for the hospital and for the population that we serve.
Thank you, David. Could I just ask, how are you getting on regarding delayed surgery that has been put back by this pandemic?
Yes, so there's no question that there is a significant number of delays in surgical pathways. Throughout this wave of COVID-19, we've continued to operate on our highest priority patients, so that's patients with cancer and those requiring an emergency or an urgent surgical intervention. However, we are very clear that we have got a large number of patients who've waited longer than a year, a much larger number of patients than we would like who've waited longer than a year for routine operations, and the size of the waiting list has grown as we've stopped doing that work to deal with the COVID pandemic. We are looking at bringing work back online over the next few weeks, assuming that the situation continues to improve and the condition of the hospital remains as it is. Obviously, we've got to balance that desire to bring work back online with the need to look after our staff. So many of our theatre staff who would look after patients who are having elective surgery have been redeployed through the pandemic to look after patients who have got ITU or high dependency needs. So we're just carefully trying to balance that mix in terms of resting staff and bringing work back online. And we'll be working hard not only within the hospital, but as an ICS, an integrated care system across Coventry and Warwickshire to make sure that we deal with those waiting list backlogs as quickly as we can. But it isn't a quick fix, and it's important to be straightforward with the committee about that. It's going to take us some considerable time to recover the situation. We're probably talking many months and possibly years before we're back into a stable position from an elective waiting list perspective.
Thank you, David. Keith.
Thank you very much for your presentation. Please send thanks to all the staff. I know they've had a horrible year. And one of the things that was dreadful last summer was the in-hospital infections. And you said at the board meeting earlier this month, last month, it's all the blur, that you are now the third best in the country. So can you explain a bit about that? And it also, last meeting, we said you're getting a new testing swab thing that was going to do rapid testing and if that's used on patients. So I'd just like to see, is all these improvements secure now? And I say it's a good news story, hopefully.
Yes, absolutely. So initially, following the first wave of COVID-19, we did experience some healthcare required transmission of infection. We worked really hard with the public health team at the County Council, with Shadi and her team, and also with Public Health England to get that under control. We've managed to pretty much retain control of that. Of course, we've had occasional incidents of outbreak across the hospital, but in very small numbers. And that's down to the processes that we put in place following our original outbreak, adding in additional pathways to keep patients separate, making sure that we're testing people on a regular basis throughout their stay in hospital. And as you mentioned, Councillor Condicourt, also introducing rapid testing at the front door to make sure that we get a result within a couple of hours and are able then to place the patient in the right place in the hospital first time, every time. And all of that has helped considerably to allow us to stay on top of this. And the staff have done a fantastic job of managing that and applying stringent infection prevention and control procedures throughout this whole thing.
Thank you. Pam. You're muted. Okay.
Thank you, Chairman. Can I just wind back a bit? Did you say elective surgery could be as long as not just months, but years behind?
Yes, that's right. So our assessment is that the waiting list has grown so much that even with the additional capacity that we've got coming online, it will still take potentially that length of time. And I would say that's not just something that we'll experience at the George Eliot Hospital, but will actually be a problem nationally.
Can you just, if I may, can I just ask, you know, in a particular surgical area is this, or is this across the board?
So there are a number of specialties that are in a worse position than others. So an area of particular concern for us is trauma and orthopaedics, and that's obviously something that we've been paying quite close attention to. Now, the addition of the 2 new operating theatres onto the site will help us to deal with that, but it probably will still result in some very long waits for people.
Thank you. Now, I don't have any. Yes, I do. Chris Bain.
Yes, thank you, Chair. Thank you, David. I was reading a report by Reform this morning, which is now out in the public domain. That had some pretty scary numbers attached to it. This is not just a matter for the George Eliot, it's a matter for the NHS. And we're going to have to get some messaging out there to counter some of this. I thought some of what it said might be, I haven't seen the modelling, but some of what it said was pretty scary. Waiting list of 10 million within a few years, and waiting lists of 6 years, and we have to find a way of countering some of this, David. So it's a question of getting together as a system and saying that this isn't across the board. It's the same for everybody, but it's not the same impact on various disciplines. And we're not comparing a hip replacement with lung cancer treatment. It's those sorts of I think refinements that we need to make, David.
Yeah, absolutely, Chris. And there is a piece of work currently underway which will do that, which will allow us to message to members of the public and the populations that we serve.
Thank you for that, David. Now, are there any other questions for David? I don't see any up, so Leslie's poking something. I don't know whether that means he wants to speak.
I was just going to say, Chairman, if I may, thank you to David, and really excellent news that he's got his extra 2 wards to complete his Sir Tom unit, because as he's been very frank and honest about the backlog, to get those 2 units working sort of by the end of the year. Yes, it delays the start of pulling the queue down, but it gives him some new capacity and commitment to the area and the people he serves to really get on with it. So thank David and his team. I think that's excellent news.
Thank you. Yeah, thank you very much, David, for that. Very much appreciated, and good luck and best wishes for getting that backlog down. Thank you very much. Thank you. I think we've now got, I think, Anna Hargrave. Yes,
Hi,
over to you, Anna.
Hi, morning. I've got some slides. Paul, do you want me to bring them up, or are you able to share them?
If it's helpful, Anna, I can share those. Just give me a second and I'll just get it going.
So, morning, everyone. Unfortunately, I know Phil was down on the agenda to talk to you this morning and this being his first meeting, but it is half term and he does have children that need looking after. So he sends his apologies, and I'm stepping in today. So I just want to give you a very brief update on the merger, recognising it's a couple of months since we last spoke to you about it.
Give me a second, sorry, just having a little bit of a technical lag here, but we should be there in a second, hopefully. If you could just confirm when you can see those for me, please.
Okay, we're up.
Yep, thank you. So if you just move on to the next slide, Paul, that'd be really helpful. All right, so in terms of it was actually September when we last spoke to you. So we, in essence, you were able to give your endorsement to our application, which was submitted to NHS England in September. And in November, we were granted conditional authority to merge as the 3 CCGs. And the conditional authority was because we still needed to appoint some of our key statutory roles, such as the chair and our governing body members. And there were some few issues that were still outstanding in terms of some of our application documents, but we resubmitted those just after Christmas, and in February we were given authorisation to merge. We've got no conditions left. We've met all the requirements now, and NHS England have been really positive about our application and really commended the team in terms of the work that's been done, especially in the context of COVID. And so that does mean that we will be a single commissioning organisation across Coventry and Warwickshire on the 1st of April. So we will be known as Coventry and Warwickshire CCG on the 1st of April. So if you move on to the next slide, please, Paul. So work's obviously going on behind the scenes at the moment. So as you can imagine, there's lots of technical things that need to be done ahead of that, relating to ledgers and HR, for example, and that's all going really well. Our governing body members have been appointed. So Sarah, who is on today's meeting, she is our chair designate, so she will be the chair of the new organisation, and we've appointed our clinical leads and lay members in the last couple of weeks as well. So we're just finalising all of those processes. And in terms of the rest of the staff, we will be TUPEing the staff into the new organisation, and on Monday this week we started a 30-day consultation with them for that TUPE transfer. So at this stage everything is all going to plan, and we are on schedule to meet the requirements for 1st of April. So just wanted to add something a little bit about the future and post-April. So Paul, if you could move on. So obviously the white paper was published last week, and it recommended that the NHS and local government come together to legally as part of integrated care systems. So obviously merging to be a single CCG was a critical step for the Coventry and Warwickshire ICS, and it reflected the requirement of the NHS long-term plan. And obviously that has now changing, and will CCGs will, in essence, it's been proposed that are abolished and ICSs replaced instead. If that goes to plan, that will be next April. So obviously in terms of how we manage the process of moving into a single CCG into an ICS, it does place us in a really good position to do that, but obviously it's not without its challenges, and we'll be working with partners to ensure that actually, as much as we try and build the single CCG, we're doing it in the context of an ICS, so that we only have to make one set of changes as far as possible with our team. So when we're looking at structures and so on, we're looking at it in the context of ICS. So we are talking to our system partners around what the future structure would be, and the skills and capabilities that we need within the organisation. So obviously lots more conversations to be had, and obviously ones that we will need to be having with yourselves as well. But obviously place is still a strong component of the ICS, and that's referenced in all of those documents produced by NHS England, and that will ensure that there's local decision making within an ICS. So that is a key area of development, and we're looking at how we resource that from a senior executive perspective as well, as we start thinking about our structure. So it was just a flag that obviously we recognise that becoming a single CCG is actually now putting us in a really strong position for ICS, and we'll try and do things as a single step as far as possible. Thank you. That's all I was going to say. So if there's any questions.
Thank you. Thank you, Anna. Could I kick off by asking, what will the new procurement arrangements be for the single CCG?
So initially, until there's a legislative change, it will stay the same. But obviously, as the white paper sets out, there will be a change in terms of the procurement regulations, which we will need to work through. But as they stand at the moment, they haven't changed yet. And so therefore, the new CCG will still need to work within that context. But obviously, that will be changing over the forthcoming year. And those changes may well influence how we start thinking about our procurements going forward, but no change as yet.
Thank you. And one other thing, I understand that all your existing staff will be transferred into the new organisation, but I assume there will be a reorganisation at some point,
yes.
which could lead to staff redundancies, etc. It's a possibility that you must have considered.
So we aren't anticipating any staff redundancies at this stage. One of the drivers to that would be a management cost reduction, which CCGs did have a requirement on, but in essence, we're already living within those new financial limits on our management costs. So yes, there will be some changes, and we will be reorganised in terms of that. And that's what I was referring to when I was saying that actually we're going to try and do it in one step to meet the requirements of the ICS, so that we only take the staff through that kind of process once, rather than doing two in quick succession. And if there's any changes in terms of, I guess if it'll be the senior teams that are, I suppose, going to be potentially most affected by that. But for the vast majority of staff, we are not anticipating any significant changes to numbers and so on.
Thank you. Keith.
Thank you very much, Chair. Two areas of concern. One is, for the last decade, I've been trying to get a GP surgery built in my division. It was the Arding cluster when we had the original planning application, and the continuous reorganisation of the CCG and its predecessors and what it becomes takes up a vast amount of time. We never get the important thing of actually having a GP surgery and looking after patients at the front of the agenda. You're continuously reorganising and having excuses as to, oh, we'll do it next year, or we haven't got enough population growth. And actually doing a lot of the frontline stuff's getting lost in this reorganisation. So can we ring fence one or two members of staff to actually get some of the infrastructure in place for our new housing? Because it has been immensely frustrating, and the NHS will always find excuses to put things off, or we need a bigger surgery, your 5-1's not big enough, we need to pretend. And it's really, really frustrating to wait and wait and wait. You've got £1 million almost from developers, you've got a hectare of land, and I just want it done. The second point I wanted to make is about the governance. I had the opportunity to go to the South Warwickshire CCG meeting and the North because they're online. Obviously, with one massive CCG, we really need to keep these meetings online. A lot of the people who want to go to them don't drive anymore, reliant on public transport, and we can do that when it's at the centre of the Neaton or the centre of Warwick. But with one massive organisation, it's really got to be very online driven, and it really needs to. The South Warwickshire CCG was a lot friendlier. They actually invited me to ask a question in the meeting, even though I was only observing. Whereas the North was very, very, you have to put your question in and days ahead, and it's all, yeah. So I do hope we take the best of practice as we merge it all together and have something where the public can play an important role, and also the lay members. I'm really frustrated when groups have lay members on them and they sit through a 2-hour meeting and don't say a word. So I really want this change to be a change for good, and we take the best. Thank you.
So in response to that, I absolutely agree, and I think obviously having people be able to join the meetings online does in fact make those more accessible, and I note your points around how we might structure things in the South differently that allow in essence people to feel more able to ask questions. So we will definitely note that, and hopefully you will have also seen, Keith, when I was asked the question about our commitment to ongoing public engagement, I gave that commitment, and that it's not just about being able to access public meetings, it's also about how we structure our processes to allow that citizen and patient voice to influence our commissioning decisions all the way through our process. And that's something that I feel very strongly about. And we start in a really good position because all 3 CCGs have been rated as outstanding on engagement as well. So that is something we are definitely moving forward. And one of the documents that we needed to produce, which allowed us to think through what we wanted to do, was a comms and engagement strategy for the new CCGs. So that's something that we are going to be obviously building on, and we want to engage with local groups to understand how the new CCG should be engaging with them, and how we can build an engagement model that hears all the voices, not wanting to take over it, but actually allow all the connections to be made, so we're hearing people's voices. With regards to your GP surgery, I understand there's an ongoing issue. Obviously, I'm not familiar with all of the details on that one, Keith, but obviously the challenge of GP estates is one that we've all experienced as CCGs, and actually I think one of the benefits of the CCG will be that we'll be able to bring that expertise together. It's quite limited expertise, and I know that as we as the CCGs have often struggled to find that level, but we do have that expertise in the teams, and actually bringing it together, and the processes that we've developed, I think, should enable us to move forward. And I think it's really critical to say that on the 1st of April, nothing is going to be changing. The staff are still going to be working on the same priorities, and that work will continue. And obviously, our ability to be able to deliver GP estate and other infrastructure changes, including digital, will be a key priority for us, and it's making sure that that's resourced.
Thank you, Anne. Barry.
Thank you, Chair. I may as well be blunt. I usually am. I am grossly and very, very unhappy with what's going on. I've never agreed that big is beautiful, and this is just one of the things that's been going on and being mentioned behind doors and secret meetings about merging these 3 CCGs. And it's been going on for quite some years, I think, and now it's come to fruition. And again, the north of the county will suffer, without any doubt whatsoever, and we will not have access to the same things that we've got now. And it's just going to start disappearing into the mist and never to be seen again, and we'll get worse service. We have very, very bad health inequalities in the North of the County. It's been known since 1992, when I became a county councillor, and nothing has changed. 29 years on, and we still haven't got anything done. And there's a delay now on the working party. So I am grossly disappointed with it. I do not think there's going to be an advantage to anybody whatsoever, and we're going back virtually to the old PCT days, and they'll be laying down the law. Somebody somewhere, some cloak and dagger person, unaccountable, will just be making decisions behind the closed doors, and we won't get to see anything whatsoever. And I think it's a backward step, and there's no advantage to anybody. Sorry about that, but that's the way I feel, and that's the way I speak. So if you're disappointed, be disappointed, because no way can I see this being any good for us in the future.
No, you're welcome to your opinion, Barry, and that's obviously what this committee is all about, is sharing those opinions amongst us. Anna, did you wish to come back?
No, I think it's probably just an offer. If obviously we have spoken about this numerous times in this arena and indeed others, and obviously the invitation's there is open. And I know obviously David and Jenny spoke at length about some of the benefits that this was bringing to North Warwickshire. So the offer is there for us to talk to Barry in kind of recognising you've not been part of those conversations, Barry, but absolutely, that is your view and you're of course entitled to it, but we can have that conversation to explain some of the changes in a little bit more detail if that would be helpful.
Thank you. And Barry, could I just say that, I mean, if you have specific issues that you wish to raise, I mean, please do, raise them at for agenda or for our spokespersons meetings to be considered. Les,
Chair, I would love to do that, but I've only got about 79 days to go, and I'm confined to the scrap heap. So I would love to have a go at that. I've been at it now for donkey's years, and I've been banging my head against a brick wall. So whilst I appreciate the offer, there'd be no point in me taking it up because I can not do anything with it. So it's just one of them. It just rankles that I've been a failure in getting something done. So
okay, but well, the offer is there. Les.
Yes, thank you, Chairman, and welcome back, Barry. Just on the CCGs, I'm delighted to hear that the staff are all going across, because I think one of the great strengths has been our joint working and our joint staff, and I'd hope to see the change to the one CCG, which I was chair of scrutiny when you all came in the Lansley days, and I never wanted a single 3 then, so I'm brilliant. As I retire, we've got to 1 because I think it's the best for Warwickshire and the ICS, and I just hope we can use this opportunity to actually do more joint posts, and not necessarily in the health field, but some of our other more social work as well, because I think there's a great opportunity now to and then link that to our 3 place forums to really make a difference and pick up some of what Barry's saying about, which is bottom up. Thank you, Chair.
Thank you, Margaret.
Thank you, Chairman, and I just wanted to say congratulations really on you've got a date now, so it's all going well, so that's all good news. I'm sort of thinking the year ahead now, and so you've just got yourself settled and then the ICOs are coming in. So is it assumed that this integrated care organisation will be based on this Coventry and Warwickshire CCG, and that basically what will happen is that other things will come into it, or is it all up in the air again and a completely new organisation?
It will be a completely new statutory organisation, Margaret. So whilst it will take the new statutory organisation will have a lot of the statutory functions of a CCG, it will have other things. And obviously CCGs were drawn from the membership of our member practices and so on. And at this stage, it's really unclear how that will work going forward, but we are expecting a brand new statutory organisation with probably a different set of duties, albeit a lot of them will be similar to that of CCGs, but we will be in a position where we're having to TUPE our staff into an ICS and so on this time next year. But this year is about actually getting ourselves ready for that, so that we are only doing it once, because we, like everybody else, it would just be such a shame to lose time to reorganising and putting our staff through that. We just want to get it done once, do it well and move on, so we can actually get on with the job that we need to. Nobody needs us always constantly reorganising, absolutely understand that point. So and it's not good for our staff, especially on the back of a pandemic as well. So we are going to try and do things once, which may mean that we might be a bit longer before we do some things, but it will be because we're trying to get it right, so we just do it a single step.
Well, good luck with your year of peace before it all goes up in the air again.
Thank you. Now, I've still got 3 hands up, Clive, John and Helen. So I will go through those and then we'll draw this item to a close. Clive.
Thank you, Chair. Actually, my question's linked to Margaret's. But I just want to sort of hone in on this comment that Anna made, that she feels confident that the merger in itself will create a stronger position for the formation of the integrated care system. Now, I can't see how that necessarily follows, but if Anna could just sort of spell out in some detail the way, you know, that will create a stronger position. Is it just a scale thing or what?
So it will be partly the scale thing, and obviously for areas that haven't yet gone through CCG mergers, that's another step that they're going to have to do as well. So they'd be putting all of their CCGs into a single ICS, so making that more complicated. So we will just have one CCG that needs to make the transition, which will inevitably make that easier. I think also by the fact that we'll be able to do the management of change process, you know, critically what we were thinking in the CCG, which is absolutely still the case within the ICS, is that kind of strategic planning function alongside our 4 places and the integration that you're delivering between health and social care in the places. So actually what we'll be able to do over this year is get ourselves in the right position, get our resource aligned to those functions, which will really support the ICS. And obviously that's not just us having to do that, it's our local authority and provider colleagues as well, but that will be a much simpler process than if we were 3 CCGs trying to do that next year.
Okay, thank you. John.
Yes, thank you, Chairman. It's Mr. Cranky here again. I just wanted to say that having listened to Councillor Kondarka's contribution earlier, I feel perhaps I'm not as cranky as I thought I was, because his was definitely a cranky contribution. Look, I know that he has his concerns about things, but really, I do think some of the comments he made in his, I know he's trying to be helpful, but they weren't terribly helpful. Everybody in the health service is going through a difficult time. Everybody is. And I don't think, you know, with respect to Keith, I think he knows that he could have been a little bit more positive in his contribution. Let's talk about the subject at hand now. I welcome this. I know David Spraggart very well. He's the GP in my local practice. I've known him for a number of years, and I discussed this with him, and he thought it was the right thing to do. Here's a man that I have a lot of faith in, and if he says that to me, I tend to accept what he says. I think we have to let this run. I think we have to see what happens, and there's always concerns when you merge organisations. I worked for a supermarket company that merged twice while I was in it, and it wasn't a pleasant experience. Having said that, it did land up for the best. So let's think positive. Let's really get on with it and give it a fair crack. And I'd like to thank Anna for her presentation. I thought it was excellent. And let's go on forward together, Keith.
Thank you. Who have we got? Helen.
Thanks, Chair, and apologies again for not being on camera. I've got really bad internet connection today. Yeah, I respect the work that you're doing, Anna, and the team, but I have huge sympathies for Barry's view, you know, in that we do spend, my experience of this committee is that we've spent a lot of time discussing this, and we still haven't had a meeting where we've discussed health inequalities across the region. We still haven't had that meeting and that discussion. And I can see Les shaking his head, but Les, I'm none the wiser as to how I mean, COVID has highlighted that health inequalities have led to a poorer result for people, you know, with such health inequalities. And that should be a massive emergency for us to tackle this in case we have other things coming up our way. We don't know whether this is the only pandemic we're going to face in our generation. Of course, we have to think about health inequalities and in relation to younger people coming forward, or massive issues. And I just don't think we've tackled them. And I think it's right for Barry to be concerned in the North, because the North has the worst health inequalities. And what are we doing? And we've spent hours and hours and hours talking about this CCG merger. The problems with it in relation to governance and transparency, I don't think have been answered properly, adequately. They come up every time we have this meeting. They come up and we're reassured it's going to be all right. But I'm not sure. And that's not to say, Anna, that I don't respect what you're doing, and I know you're trying to move forward in a positive way, but they're my concerns anyway. Sometimes I think we've got the wrong priorities.
Okay, Helen. Did you want to comment, Anna?
I think we're doing a huge amount of work on health inequalities, and I accept that you've got the task and finish group, but across the system, we are doing a huge amount on that. So I think maybe that's because we need to talk to you about what we're doing. We've obviously had the COVID health needs assessment as well, so we're starting to understand that, and we're starting to have conversations now around what are our priority groups in terms of addressing health inequalities and so on. So that work is absolutely going on. Has it been to this committee? No, and that's something that we can address or can be picked up through the task and finish group. So I can absolutely see why you might think we're not doing anything, but I think it's about us talking about it with you, because we are doing things on health inequalities, and we're thinking about how we as a new CCG and the ICS start tackling those in a much more robust way than we have done, and rising to the agenda in terms of prioritising our programmes on the basis of health inequalities in a way that we've not been able to do before. So we can talk about that at length, and I'm very happy to do so, but it's just that we've just not brought it to this committee.
Thanks, Anna. Can I come back on that, Chair? I know. Sorry.
I said briefly, please.
Yeah. I know that we are doing stuff, and I'm not saying we aren't doing anything. But if you listen to what Barry said in 1992, he said that he was talking about this issue, and that's 20 odd, 30 odd years later, and we've still got the same problem in Warwickshire. It is a gaping question, isn't it? It's the elephant in the room, really, isn't it?
Okay, thank you for that. Now, I did say I was going to draw the line, but three of you have had the cheek to put your hands up. So, Dave, Keith and Jerry, and after that, after Jerry's spoken, there will be no further discussion on this item. We will be moving on. So, Dave.
Thank you very much for your indulgence, Chair. I was a late caller, so thank you very much. I will be brief. And it is basically along the lines of what Barry and Helen have just said. What we really need in the north is we need some results, to be honest. And I don't want to go into the ins and outs of where we are and all the rest of it, but what we need to see is results, and we need to see the inequalities absolutely tackled and prioritised. And if we don't do that, then it's a failure. It really is a failure. That's the challenge that faces our county at the moment. It is the health inequalities, and if we don't do anything about that, then we have failed, and that's what we've got to bear in mind. So that's my point, and I hope it can be a positive point, and I hope it can be something that we really do focus on. But that's what we've got to do. Thank you.
Thank you, Dave, and your point is well made. Keith.
Yeah, I must come back because I was accused of being cranky. I've been waiting a decade for my GP surgery, and I started becoming cranky 18 months ago, 6 months before the COVID pandemic. And there is the opportunity here of having the new South Warwickshire CCG, which has been high performing, getting stuff done, to actually hopefully get my GP practice built in a reasonable time. And I hope the new administration will actually have an urgent meeting with me as soon as they're formed and get a roadmap, because we have a health inequality. I was surprised by how many people in my division actually go to GPs in Aviston and got vaccinated first, because there's a lack of GPs in the Neaton, and it's actually a lack of GPs that increases the health inequalities. So I'm passionate about getting my GP, and I'm going to get even more cranky if it doesn't happen.
Okay, Keith. Jerry.
Thank you, Mr. Chairman. Experience tells me that governments will always tinker with the NHS, and they will always have reorganisation. Ever since I've known this subject, there has always been reorganisation, closures of bits, things happening, and stuff going on, really. And I think I've seen Anna in various positions, in various roles over the years, doing different jobs and, you know, one thing and another. So we can all blame Secretaries of States and any governments, because that seems to be the order of the day. It doesn't matter who's in or what's going on. The bit that does interest me is actually when we get further on into the agenda, there's an item on scrutiny, and perhaps we should be looking and talking about that and about how we work with organisations and ask the questions going around. You know, I recognise Keith's point about wanting GPs and surgeries. You know, Keith, it's the same in rugby. It's the same, all over. Health inequalities, yes, that is a massive issue. You know, the draft public health report from the Director of Public Health touches upon some of these issues as well. You know, and perhaps we need to be focusing around those as we look at what scrutiny will look like in the future. Because I can tell you now, I won't be around, but in 20 years' time, the NHS or whatever it might be called, there will still be reconfigurations, there will still be changes going on. So I think it's up to probably the scrutiny committees and portfolio holders to make sure that our agenda is kept to the particular matters that in hand that are going forward, and how the work programme is then shaped on that. But can I thank Anna and the crew for all the work that they're doing, because, you know, COVID has been around, the pandemic has been around, and I have seen people, you know, who are literally at the end of their tether and cannot carry on working. They're on their knees, and therefore, you know, we need to get through this. There will be brighter times ahead, but also there's a massive mountain to climb. So it's very easy to criticise, I think, Mr. Chairman, and very easy to make comments. But actually, what I'm interested in is finding solutions, and bit by bit. And, you know, and I'm going to say it today, I'm glad the Children's Commissioner has come out and said what she said. It's exactly what we've been banging on about for years, early years, families and support. And, you know, lo and behold, the other day, what was in the news? Self-harm. What we've been banging on about? Self-harm. But, you know, need to find the solutions, and that's what we're doing with the case of Hotas and the other. Thank you, Mr. Chairman.
Thank you, Jerry. I'm going to ask Anna or any member of her team who may wish to make a final comment, but I have had a request from the Chief Executive's office. Those of you who are not speaking, would you turn off your camera, please? Anna, over to you.
Yeah, thank you. I think actually my comment was actually, I think Jerry's point is absolutely right, and I think there's something about actually addressing health inequalities isn't just the job of the NHS, and it's about how we work together as partners, not just in social care, but the wider council as well, and our other partners. And so I think that is absolutely the focus in terms of you having those conversations around scrutiny. It's actually how do we get scrutiny on those partnerships working together to reduce health inequalities, because we are, in essence, we can do a lot within health, but obviously in terms of the wider determinants and so on, then we need to be working with our partners. So I think that's a really critical point, and thinking about how scrutiny goes forward, I would kind of recommend that is something that is thought about, and how we work with you in that context.
Thank you very much, Anna, and thank you and your team for spending the time with us this morning. Very much appreciated. Thank you. Going on to item 6, which is the West Midlands Ambulance Service, and we are to receive an update from Mark Doherty, who is the Director of Nursing Quality and Clinical Commissioning at the West Midlands Ambulance Service. Mark, I see you there. Welcome to our meeting. Thank you very much. And over to you.
Right. Okay. Thank you, Chair. My colleague Pippa is on the call as well. Yes. And what we intend to do, we've got a presentation that we're calling an information pack. So the idea isn't that we spend lots of time on every slide, but you'll get a gist of what we're doing, and we're very happy to talk in detail about any specific issue that crops up. Pippa's going to do the technology, mainly because I don't understand how it all works.
I'm hoping it's coming through to you now. If you could let me know when it's available on your screens.
It is on your. It is on the screen.
Thank you.
So I think the first thing to say is a huge thank you for inviting us. We're always really pleased to come and talk to you about the work we're doing, but also receive feedback by way of priorities. And it's been really good listening to some of those discussions ahead of us presenting, because we really do understand the issues that people have concerns about in Warwickshire. And I'm sure we'll touch on some of these as well. So Pippa's going to whiz through the slides, and I will try and keep pace with her, because we recognise we haven't got loads of time. So most of you will understand that we're a regional service, we're a large service, we're one of 10 ambulance services in the country. We're very much geared towards being a regional service, but we try to provide a local flavour. We're very much a vehicle-based service, so we have lots of fleet, 850 vehicles in our fleet, and we've got around 5 helicopters that we use as well. The reason I say that is that actually that puts a large onus on us by way of our carbon footprint. We spend, we do over 18.5 million miles a year in our vehicles, and we do contribute to the air quality. So we'll touch on some of that as we go through the slide. So we've got a vision and strategic objectives. We are always reviewing these. We've recently appointed a new director of strategy who's working with Pippa to make sure that our strategic direction is relevant to the current situation, the NHS that we work in, and the type of work and our place within integrated care systems going forward. Now, by way of COVID, I want to talk specifically around the COVID challenge, as well as other things. So many of you will know that we went into the COVID period absolutely exhausted. So we'd had the floods in West Mercia that had gone on for some time. For a number of weeks and months, we had 3 major incidents running in West Mercia. And many of you will have seen the floods around Iron Bridge, where our role within that was very significant by way of having a local presence. We got no headroom. We went straight from that. In actual fact, we pulled our resourcing into those major incidents early in order to respond to COVID. COVID's been a really unusual place for us, because if you talk to most staff on the ground, they'll say that actually we've been inundated with calls. That is the reality, but what you'll see from pure numbers terms, the number of calls hasn't varied dramatically on the previous year. What has changed, though, is the way that the calls come in. So hidden beneath these averages across each month, there's been huge spikes and dips. So on occasions, we've had activity running 30% above where we'd normally see. In the first phase, we were fortunate that people tended to do what they were told. They stayed at home. They didn't drive out in their cars. They didn't fall from apple trees and various other things that we normally see on a day-to-day basis. So in the first phase, certainly things like major trauma reduced dramatically. And the types of incidents we were responding to were more of the COVID-related incidents. What we've seen more recently, and you'll all see it if you go out and need to travel, the roads are not massively quieter than they would normally be on a normal day. And some of the driving, for example, beggars belief. So we're seeing major trauma back to where it was. And in actual fact, some of the trauma we're seeing is actually significantly worse than we would normally see. We're seeing levels of suicide, self-harm significantly up. We're seeing domestic violence, homicide and things like that up. And I don't know if we've not looked at it in detail, but I get a text every time we have something of significance, and fires in houses seem to be higher than I would normally expect. But whether that's significant or not, I've not done any sort of analysis on. So we're busy. That's the underlying message there. Although we're not busy by way of activity. So roughly our activity's about 1.5% different to what it was last year. The type of activity we're getting, so the type of patients are generally sicker than we would normally get in an average year. Now, you're always keen to hear about performance, and I get that. Needless to say, performance has been really, really challenged this year. It's been challenged on a number of fronts. We've obviously, our resourcing model is dependent on us being able to deliver a service. Our staff, like the general population, become unwell, they get COVID, they get symptoms, they screen positive. So our abstractions of staff have been higher than they would normally be. In order to compensate for that, so if we take an average day for us pre-COVID, we would put out around 350 ambulances on an average day during the day. During COVID, we've been putting out as many as 520 ambulances during the day. So we've compensated for any loss of performance. And the other thing is, of course, we've had tremendous handover delays at our hospitals across the region. I will pick up on that because there's a good story to tell in Warwickshire, by the way, on that one. So I'll go through these fairly quickly, and again, I'm happy to answer any detailed questions. So the purple box illustrates our category 1 calls. These are the lower number, but they're the people that are absolutely time critical, so not breathing, cardiac arrest, that type of thing. And we tried to get there in a mean average time of 7 minutes. And you'll see that, broadly speaking, across Coventry and Warwickshire, other than South Warwickshire, we're doing pretty well. And in actual fact, even for South Warwickshire, when you take account of the rurality, some of the villages that we've got that we're serving are more than 7 minutes apart. So, you know, the logistics of actually getting a vehicle there within 7 minutes are really difficult. But you'll see from the 90th percentile, where we try to get there within 15 minutes, we're meeting all those targets across each of the CCG footprints. When you go on to the category 2, which is the red one, these are the people that have time critical medical emergencies. So these are things like heart attack and stroke. And you'll see that our mean average response time is 18 minutes and our 90th percentile is 40 minutes. So the 90th percentile basically means that for 90% of people, we should get there in under 40 minutes. Now you'll see we're easily getting there in the mean average of 18 minutes, and we're easily getting there in the 90th percentile of 40 minutes. Now, this is a really critical group of people because their onward care, their ongoing recovery is very time critical. So that's a very, very reassuring number. Category 3, we have no mean average response time, but we have a 90th percentile. So for 90% of people, we should get there in 120 minutes. And you'll see that we're easily achieving that. These are people that, whilst they're okay, they may start to develop problems if we leave them a long time. So what you might find is we've got people in this category that are maybe having problems with their breathing, or they've maybe fallen and we don't at that point know the cause of the fall, that type of things. And then the category 4, which is the green coloured box, we've got a 90th percentile of 180 minutes, and you'll see that we're easily getting there in almost half that time. So the message to go away with here, I think, is that we're hitting almost all of the targets. Clearly, the category 1, we've got some challenges on, but even pre-COVID, even in an ordinary sort of period of time, where areas are very rural, we always will struggle to hit a mean average of 7 minutes. And that's where the to help us deliver a good outcome for patients where we're not getting there within a 7-minute mean average. To put this in context, these are some of the best performance figures in the whole of the UK at the moment. You've got some areas where they're struggling to answer the phone or really struggling to get patients within time frame. So I will assure you that these response times are excellent, and putting it into the context of a COVID pandemic, these are absolutely superb response times.
Mark, can I just add, it's worth just providing added assurance on the location of defibrillators and the use of defibrillators and community first responders, where we're using those for category 1, but they don't actually stop the clock. So we actually often have help in those cases before that time. But the clock doesn't stop until we have a WMAS resource on scene.
Yeah, that's helpful. Thanks, Pippa. Chair, I noticed that there's somebody with a hand up. Do you want me to take questions as we go along?
No, if you would finish the presentation.
Thank you. Now, call answering is a really critical part of our role, because clearly if we don't answer the call, we can't help anybody. So we measure a number of factors. So our aim is to answer the call within 5 seconds. Which means if you call 999, get put through to our ambulance service, you often won't hear the phone ring. We answer almost every single call in under 5 seconds, but clearly there are times when that doesn't always happen. So what I've presented there is a number of figures by call answering, but the one at the bottom, the table at the bottom, you'll see the number of occasions where the call answering goes over 2 minutes. Now, that's something we take very seriously. So if you take the fact that we answer more than 1.2 million calls every year, on a very, very small number of occasions, we get calls that do go over 2 minutes. Sometimes these are calls if we have a big event happens and you get hundreds of calls about the same thing. You literally cannot keep up with all the calls answered all at once. So you might get a big crash on the M6 and you might get multiple calls that are all about the same thing. You've answered the first call quickly, but you can't keep up with the rate at which the calls are coming in. So you'll see that compared to the England mean, we are very, very well placed by that performance. Now, conveyance rates is another thing. Often we get accused by commissioners, the problem with your service, they'll say, is you just take everyone to hospital. Well, if you look at the conveyed to ED column there, you'll see that, roughly speaking, about 50% of the calls that we receive, the 999 calls, we actually don't take anybody anywhere near a hospital. We manage it either by taking people to alternatives or advising them to go to alternatives or treating them on scene and discharging them on scene. That's one of the highest levels of non-conveyance in the whole country. As an ambulance service, we're the second highest non-conveyor in the country. Now that's good, but equally we need to be cautious of that, because clearly there are people by nature of our service that need to go to hospital. And we need to just make sure that we take the right people to hospital. So that's the measure from our point of view. I'm going to try and speed up a little bit here, because I recognise there's quite a lot to get through and people will have questions. So hospital handover trends, you don't need to look in detail at the numbers other than to say that I've recently written to the George Eliot Hospital and Warwick Hospital congratulating them on their performance by way of not keeping us waiting when we go in. UHCW are a little bit more of a challenge, but that's mainly because they're a much bigger hospital and we take so many more patients into those hospitals. But their performance by no stretch is poor compared to other parts of our region. We've got very big challenges at the moment in Birmingham and the Black, where we have sometimes handovers lasting over 7 hours, which we find completely unacceptable and completely disruptive to delivering an emergency ambulance service. But for Warwickshire and indeed for Coventry, because many Warwickshire patients go into UHCW, we don't have those concerns. So those delays by hospital, you'll see the George Eliot particularly has made dramatic improvements on maybe their past performance, and that's not to say their past performance hasn't been very good. It's a shame that David is on the call, so a huge thank you to David and his colleagues for what is probably the best in the region performance. So a huge thank you, David. That's over the delays across our whole region, and you will see from the sort of brownie, sort of Moby sort of column that actually the performance has got really bad this year. So the fact that Warwickshire have made improvements and held their own, I think is a real accolade to their performance, and one that we shouldn't let go unnoticed. So as far as COVID is concerned, I'm not going to talk in detail because I know the next presenter is talking about it. The levels are going down, but it's still there, and we need to make sure that we're not becoming complacent. So PPE was a big issue for us in the early stages, and still is. So we use two forms of PPE. The picture on the left represents our standard PPE for every patient, which is what we call level 2. Level 2 PPE consists of an apron, a pair of gloves, and a surgical face mask. Level 3 on the right-hand side is different to most organisations. So pre-COVID, about a year before COVID, we made a strategic decision to move away from masks for level 3. If you use a mask for level 3, it has to be properly fitted. And for some groups of staff, it can be difficult to obtain a fit. So, for example, if you have a beard or facial hair, it can be difficult to get a proper seal. Equally, if your face shape changes over the years, so if you lose weight or put a bit of weight on, that can affect the fit. So we moved to powered respirator hoods. So on the right-hand side, you'll see level 3 PPE, which is what we call a Tyvek suit, a bit like sort of a decorating overall, but these are really robust and waterproof. Gloves again, the respirator hood. This is a person from the back, by the way, to show the respirator unit, which is battery powered and has filtered air supplying it. So that's what we should have. This is pictures of what we actually were given in the early stages. So the left picture shows the aprons that we were given. You'll see the one on the far left. It wouldn't fit round the smallest of our staff, let alone the average or the larger of our staff. They were very short. They barely covered sort of below the waistline. They were massively thin. So even trying to put them on, they would break, or you put your fingers through them. And the other thing with them is out in the open, they'd flap in your face. So however good they were at catching droplets, as soon as you went outside, the apron blew into your face and all those droplets contaminated your face. So that was the standards that we were being delivered early on in the COVID period. And you'll see the colleague in the middle actually wearing one of those, probably of minimal use, if I'm being honest. You know, it leaves lots of the body unprotected, and it doesn't have any rigor to it. So as soon as you go into excuse me, an environment where, you know, maybe a patient's shoes rub up against the apron, it will just disintegrate. On the right hand side of the left picture, you'll see a dark blue apron, which is, we decided early on that we wouldn't accept just being issued with poor equipment. We would order our own, we would devise our own, get them manufactured, and that's exactly what we did with the aprons. We got proper robust aprons that, I mean, some people will say that these aprons are thick enough to sort of line a swimming pool. I'm not sure if that's true, but that sort of gives you an idea of how robust the plastic is on them. We're not saying the aprons that were issued were inappropriate, by the way. They're probably fine for a dental surgery or a GP practice. They weren't any good for using in an outdoor environment, which is a lot more rough, windy, wet, exposed. The right-hand picture is the masks. Some of you will be aware that the use-by date was over-labelled on a number of centrally issued masks. When we took them out, they literally disintegrated. So we had great problems early on with PPE. So this is going on to, you'll be aware that we also provide a 111 service to the West Midlands. We've provided it since the 5th of November 2019. We agreed to provide it on a commercial basis from the previous provider, Care UK, and we agreed to deliver 100,000 111 contacts every month for an agreed amount of money. You'll see that pretty much other than 1 month of the last sort of 18 months, we've never gone below. And we're currently running about 35% above activity. Now, for the first 6 months of COVID, we had this overactivity funded. Since then, we haven't received any additional funding. So what that means is we're going into a period where we're really struggling with the activity of one, and it means that we don't really have all the infrastructure we would like in order to deliver a robust 111 service. It's all well and good answering the phone. That's probably the easy bit. It's the clinicians behind that you can avoid patients having to go to their GP or go to the ED. Because if we're just a phone answering service and we just direct people to other services, it doesn't actually help the system. The system still is as busy as ever. So we're in the process of talking to commissions about that. A number of 111 initiatives that we've done. So, excuse me, we very much take the view in our service that this is business as usual. We're a service that's designed to be there when people need it. We're not going to use the we're not going to use the excuse of COVID to say we can't deliver. We still put in place robust systems to handle the demand. And this year, we've also put in place the Think 111 First programme. The idea being that if someone's about to go to ED and they're thinking, I'm not so sure about that, give 111 a call and we'll make sure that you only go to ED if that's absolutely necessary. As far as COVID goes, going back to specifically COVID, from the very beginning, we've had a robust test and trace process in place. Before staff testing was even started properly, we had 1,000 members of staff off due to being exposed to COVID. I was given the task of getting all those staff tested. And that was when, in our part of the region, fewer than 1,000 staff in the whole of the region had been tested. And I was set the task of getting 1,000 of our staff tested in the weekend. Now, I've previously run a pathology laboratory at the George Eliot Hospital, and I know a bit about the testing. So I managed to find a service in the Northwest that tested for sexually transmitted diseases. And some of those are tested through what they call the PCR test, which is the same type of test that's used for COVID. So I managed to get that company to sort of jig their machines and actually run us 1,000 COVID tests in a week. And now, interestingly, that laboratory is in an industrial estate in Ullersthorpe, which, I mean, people know Ullersthorpe just outside Rugby. So it's literally on our doorstep. And we didn't even know it existed, but they pulled out every single stop. And we got most of those 1,000 staff back to work within a weekend. And that was the start of the NHS realising that test and trace and testing staff through the PCR route was actually a really important part of controlling the pandemic. We've had really good vaccination figures, and we've got really good relationships with people that are doing the vaccinations and also the PCR testing. It's been a real sort of a real team effort with all parts of the NHS and other sectors to come together to deliver that. So we've dealt with unpredictability. We've all been in this. No one's ever lived through this pandemic before. We didn't know how it was going to pan out. And you'll see one of the things was this complete unpredictability. So you'll see that 16,000 calls in one day through 111, 500% the activity we would normally expect. We've not had peaks quite as high in the 999 service, but we've had 30% above when you would expect. So, and in these services, you know, when you draw the graph, it doesn't look very dramatic, but sometimes these all come in within a 2-hour period. And then for the rest of the day, it sort of goes back to some normality. So it's not just the peaks in the day in total, it's the peaks at particular times in the day. And we've seen numbers that you just wouldn't have thought possible. The phones were literally running hot for ages. But what we've done is we've continually learned, we've amended the rotas, we've taken on additional staff. We haven't just sat back and said, well, it's too difficult, we're not going to do. We've got on top of the demand, and we've delivered. The other thing actually with the 111 service, we had an outbreak of COVID in the 111 service up in Brierley Hill. So what we found was that we were sort of partitioning the call handling areas. Staff were washing their hands. We had everything perfect. And then they'd go on their lunch break and they'd all go and sit in one person's car. And so there were things happening that you think it's not the staff fault, because when you look at what the ask of staff is, it's really difficult to keep your guard up 24/7. But we very rapidly found that there was links. Things also like a communal box of chocolates. People were being very staff chocolates, but actually the process of passing the chocolate box around was a point of contact of potential cross contamination. So we were classed as an exemplar by way of how we got a grip of a work-based outbreak there. The other thing is we're continuing to learn from this. Now, I don't think we'll get back to a normal way of working. I mean, many of us have only been in our headquarters building 3 or 4 times in the last year. Anyone that goes in there, whereas a quarter of the building was a call centre and the rest was our headquarters, now pretty much it's 95% that's call handling. We've spread the call handlers out. There's no ability for most of us to go back. And it's interesting, whereas normally I would probably attend a meeting like this in person, I would drive 45,000 miles a year for work. Now my lawnmower has done more miles than my car. So in a lot of respects, we found new and different and better ways of working. And I don't think that the service has been disadvantaged. I think, if anything, we've got a much more robust way of working now. I won't dwell on this because actually we can talk about financial things. But staff well-being was a really significant thing for us. I mean, getting all our staff vaccinated very, very early on was really important. So, as an example, I mean, I had my vaccine at the beginning of December. Many of our frontline clinical staff were first in line for that. We were one of the first NHS organisations to open up the vaccine programme for every single member of staff, not just what we would class as frontline clinical staff. Because an example of that is, definition-wise, a call handler wouldn't be classed as frontline, but actually, if no one answers the call, the patient's going to die because we can't help them because we don't know they need help. And also working in a call centre where there's lots of staff is a particular risk. And the other thing is we've done lots of proactive work supporting our colleagues that are at a higher risk. So people that are shielding, people from BME backgrounds and various things. And then the other thing is many of us have put in online support services for staff. So, I mean, Pippa is part of the team that joined me in briefing our staff. So my team will get briefed initially every single day of the COVID outbreak, and then more recently 3 times a week, every single week. And that's something that's continued for over a year now, which I think is really, some staff do struggle with more remotely, and we've been able to make sure that those staff are supported. But also, more importantly, if they haven't got the equipment, at the very beginning, I promised to buy every single member of staff the correct equipment so that they could be effective working remotely. And we've delivered on that promise. We've got testing available, so our testing involves a number of things. We've got the antibody tests, the antibody serology that we test. The other significant one is the lateral flow tests, which every member of frontline staff has been issued boxes of those. So we're encouraged to test ourselves twice a week and record those results. Those tests are not particularly accurate, but the more you do them, effectively, the more of a better picture you're getting. So we've got access to the whole range of testing, and our staff probably are tested more than most other health service staff. They can't move without being tested almost. So we're getting ready for the future. Now, none of us quite know how this is going to pan out, but our view is we'd rather be over-prepared than under-prepared. So the priorities for us is that we are recruiting more staff for next year. We've had a discussion yesterday, our executive team, We don't know whether we'll get a fourth wave. If there is, we don't know when it's going to be. But we'd rather have too many staff to cope with the future than too few. So we'll be putting in more staff into the frontline 999 service and also our 111 service. We will be trying to integrate. So if you know, our plan was to integrate the 999 and the 111 service this year that's just gone, but COVID got the better of us. We've integrated some staff, so some staff are dual qualified to answer 111 and 999 calls, but the idea will be that we'll have almost all staff that just pick up the phone and whatever call it is. And we would integrate our actual call handling facilities, so we'd move them all mainly into one area in the Black Country, which would be Navigation Point. But actually for the Coventry Warwickshire calls, they're answered in Staffordshire in our tollgate control room. So both of those would have the ability to handle 111 and 999 calls. We're learning from the COVID thing. So one thing we learned very early on is our control centres were very vulnerable. If one of those got wiped out, we were in a real pickle. And actually, the learning from across the country, so Yorkshire had a problem with a control centre being wiped. And I think London was the other one. Now, what that meant is that their calls had to be routed to other parts of the country. So some of those services where I say to you, we answer our calls in 5 seconds. Some of those services were taking as much as 10 minutes to answer a call. Now, clearly, if you answer a call in 10 minutes and you've got a person that's not breathing, well, they're not going to stand much chance of recovery. So call answering is really critical, and it's really critical that we get that that we get that right, because every subsequent part of our service is dependent on call answering that's quick. So we've done that, and also we've explored the idea of clinicians working from home. It's not easy because we've got such complicated technological infrastructure. But what we found is some clinicians that handle the clinical calls, as long as we've got the right information governance, i.e. they're in a room that's not overheard at home and people can't see the computer, we can do things remotely. And that's really important because that gives us huge flexibility, particularly with people like GPs. We might want them to work 3 hours on a Saturday morning, but if they have to get into work and an hour home, they're not going to do 3 hours. Whereas actually many clinicians would be quite happy to log on for a few hours every weekend morning. So one of the things I can assure you, even though there's been a pandemic, we have been delivering 100% by way of our innovations, moving things forward. We haven't had our eye off the ball, and we're not going to say because of COVID we're behind in our developments. Our fleet continues to be the newest in the country. No vehicle over 5 years, unless it's a very specialised vehicle. So it might be our mobile control unit, which is like £500,000 worth of vehicle. It's not doing the miles, and it wouldn't be right to replace that every 5 years. But every single frontline ambulance in that under 5 years old. And actually, this year we've brought into the fleet the first all-electric ambulance in the whole of the UK. We think it might actually be the whole of Europe, but we don't want to be too ambitious in that statement because it's certainly the first in the UK. So it's fully electric, and it does about 110 to 120 miles on a charge. It has really good torque, really good acceleration. It's really comfortable, and as you'll see from the inside of the ambulance, it looks very much like a traditional ambulance. It's just the power horse. And our ambition in the next couple of months is to get one of every type of vehicle on our fleet electric. So where we've got patient transport ambulances, we'll have one of those that's electric. We're taking delivery of our officers' response cars. More than one of those will be electric. I think they're the BMW X5s. So great ambition, and the ambition going forward is that we'll have reduced carbon hubs. So we're looking at putting wind power and solar power panels into those, so that our aim is to get a zero carbon emission footprint in the near future. A lot of work in the communities. So we recognise that one of the things that's really important is basic life support. So if we can get basic life support developed, more people can keep patients alive till we get there. You know, if someone's in cardiac arrest and they've got a cardiac rhythm that we can defibrillate, every minute that goes by, the patient's chance of survival reduces by 10%. So early defibrillation will always be the answer, even in areas where we can get to the patient in 7 minutes. We need to make sure someone has access to a community defibrillator. And you'll see, we're not talking small numbers here, you know, 67,000 people trained this year in basic life support, which is really good. And then the other thing is, I mean, many of you will have read the Ockenden report in relation to Shrewsbury and Telford hospitals. We've been inherently involved with the Ockenden report. We dealt with the parents of Kate. Kate sadly died as a newborn baby. And we've been very much involved over the last 10 or 12 years with Richard and Rhiannon, Kate's parents, by way of wanting to see improvements in maternity care. Now, we aren't a maternity care provider other than when we get called in an emergency. So we take a lot of feedback from our patients, and one of the feedback was if a patient is born asleep, as sometimes happens, either because they're full term and they're not viable or they just die, or because they're preterm and can't survive, we didn't have a dignified way of allowing the parents to cuddle the baby. So particularly for babies very preterm, it's very fragile. And so we've come across the idea of cuddle pockets. In other areas, they're called angel pockets. So if you Google that, you'll get an idea. What we've agreed is that with immediate effect, we're putting these on all of our ambulances so that if we have a child, preterm baby that dies, in a very dignified way, we can help the mother bond with that preterm deceased baby. And the mother goes away with some memories rather than just a baby that's sort of wrapped up in tissue or, heaven forbid, a clinical waste bag or anything like that. So we take these issues really, really seriously. And of course, many of you will know that we're one of only a handful of ambulance services in the country to employ our own senior midwifery advisor. So Stephanie Henry is one of our employees. She also delivers babies at the Women's Hospital in Birmingham. So we're very pleased to have a practicing, very expert midwife on our team. And the other thing we've introduced this year is what's called a transwarmer blanket. So the evidence is when a baby's born, it loses heat very quickly. And cuddling the baby in blankets is one thing, but when you're actually out in the cold or out in a van, it's not easy to keep these babies warm, and they only need to lose a little bit of heat before they rapidly become very, very unwell. So what we've got is these transwarmer blankets or mattresses. What you do is you open them, and it's sort of a gel that self-warms. The gel goes a few degrees above body heat, so that by wrapping the baby in the mattress, it ensures that the baby's got access to heat rather than cold, and the baby stays warm. And these are being rolled out on we've got them in stock now. We took this, for some of these things you think it's not worth debating, they're so important to just do it. And that's what we've done. We've got these rolling out to all the ambulances in the fleet. The quality account is something that we've involved you with in the past. You'll see that we had some priorities for this year that we're in. And I'm glad to say that despite the pandemic, we've continued to deliver on our quality account promises and priorities. We will, however, want to have a discussion with the scrutiny committee about the quality account going forward. We are of the belief, and I've probably oversaid this, the pandemic is here. We've got to live with it. We've got to get through it, but it doesn't excuse us developing and moving forward and delivering the ambulance service that the people of Warwickshire and indeed Coventry and the rest of our region deserve. and we will absolutely commit to moving forward all of our developments despite COVID. We're still awaiting some of the planning guidance for the coming financial year. There are things that we want to take forward going forward. NHS 111 is still fairly new to us, and we want to use patient feedback to continue to develop that. It's a significant part of our work, and probably by the end of this year, numbers terms, we'll probably have more patients going through 111 than we will 999. So you can start to see how there'll be a change in shift of focus. And going forward, we'd like 999 to almost be used as an emergency line, as it was in the past, where people have got a good alternative that gets answered quickly and people get a good response. Now, the other thing is maternity services. You know, we have over 4,500 maternity contacts every year. They're not all babies being born, but a significant number are. And you know what? We don't get the easy births. Sometimes we do. Sometimes the baby's already born by the time we get there. But inevitably, we get more than our fair share of complex births, and we want to make sure that our response to maternity emergencies is as robust as it can be. Now, that's the end of our talk through information pack. I hope we haven't spent too long going through that. Clearly, we're really keen to get feedback. We're really keen to enter a dialogue with colleagues around Coventry and Warwickshire about what we can do to improve our services for your population, for our patients, so that collaboratively we're doing the right things. So I'll finish there, Chair, and pass over.
No, thank you very much indeed for that presentation, Mark. It certainly, I think, covered all aspects, and in particular to us here in Warwickshire. Unfortunately, I lost Wi-Fi contact at one stage, so could I just ask, kick off by asking one question? The ambulance staff, their training, what level of training do they receive? Are they paramedics or?
So, Chair, the majority of our staff, so if you remember going back 5 or 6 years, we made a pledge that there would be a paramedic on every frontline vehicle. So that's our priority. So when we train people, we tend to take in student paramedics. And at the moment, there's 3 ways in which they can train. The first is through our in-house training, which gives them a foundation degree as a paramedic. And at the end of 2 years, they're a fully qualified paramedic. And then they enter into a 2-year newly qualified paramedic program, at the end of which they become the next level up paramedic. The other way is that they can just pay their whatever, £9,000 or whatever, they can go off to university. They can become a student for 3 years and they can train as a paramedic and they do placements with us. The next opportunity they're going to get from September is a 4-year master's degree program at Keele University. So that program, again, a bit like an undergraduate student, they'll pay their money, they'll go off for 4 years, but they won't just train in the ambulance service to be a paramedic. They'll train in primary care and they'll train in hospital care. So at the end of their 4 years, there'll be a paramedic who can go and work in a hospital, work in a GP practice, or work on an ambulance.
Right. Okay, thank you. Chris.
Thank you, Chair, and thank you, Mark and Pippa, for an interesting presentation. We've been become accustomed to saying that people are delayed contacting the NHS when they really need them because they're anxious about COVID, and that as a consequence they're sicker by the time you get to them than they would have been without COVID. And I just wondered, firstly, is that your experience? And the second thing is we're making assumptions that there is more mental illness now out there in households, and when you go visiting, have you been seeing that? Have your paramedics been seeing that when they've been going out? So it's the 2 things: are people sicker of delays, and is there more mental illness?
So Chris, I think the answer to the first question is very, very early on in COVID, we had exactly that concern about people delaying contacting us. So we formed a partnership with Birmingham University and Warwick Medical School. And I think Gavin Perkins was the name I remember at Warwick Medical School. And we analysed, what we took is we took some indicator conditions that we could analyse in detail to see if that was the case. So what we did is we took stroke and heart attack as the two indicator conditions. And we looked at those over a period, I think it was of about 3 months, just to see whether it was the case that we either had fewer or there were later presentations. Now, in the first few months of COVID, we didn't find any evidence of that. So much so that actually we published that. I want to call it research. It's probably more audit. We published that in the Lancet very early on. I think since then, the evidence is probably that people are delaying coming forward. So what we're not saying is it's a fixed picture. Early on, we don't think they did. But actually, there's enough evidence now from other studies that we think that people are delaying. And we're certainly getting to people that are late onset heart attack. So they're almost peri-arrest, so that when we get there, they almost have a cardiac arrest as soon as we get there, which would suggest they've delayed it longer than they should. We've not gone back to that empirical evidence, though, because we don't see the point in repeating things that just clarify other national studies, if you see what I mean. But by way of the mental health stuff, I think absolutely every person I talk to would say, yes, it's absolutely there. You know, the symptomatic stuff that you would say, people that are suffering in crisis, don't know where to go, people that are doing things that are you know, suicide being an example. You know, almost every other day we're seeing people on trains, jumping off the bridges, things that in the past would have been the occasional sad incident. Now too much are becoming commonplace. And then the other things that are, you know, linked to mental health, you know, the domestic violence, the children that are being beaten up, for want of a better word. There's definitely, I would say, evidence that that's more pronounced than we would normally see it in situation. I mean, this morning I was on the phone to our mental health lead nurse in 111. I had a catch up for an hour with her, and she's saying it's definitely, they're getting more and more cases of mental health crisis. You know, it's people that, whatever reason, you know, and well, you do see it, don't you? I mean, I haven't had a mental health problem, but some of these people are living with no money in blocks of flats, not able to afford to feed the kids, not able to heat the flats. And you just wonder, you despair as to how anybody could cope in that scenario. And I was interested in the bit around the health inequalities, that discussion. You know, having lived in Nuneaton myself, you feel the health inequalities, can't you? I mean, I live just down the road from Nuneaton now. I'm not quite in North Warwickshire, but not far away. And you do see people that you just wonder they're going to cope, not just in COVID, but as we come out of COVID, we get back to normality. But some of these people are on a long, long road to recovery, aren't they?
Exactly so, Mark, and it needs a system response to it. It's not something you can do alone. I think the whole system needs to respond to it. Thank you, Mark.
Thank you, Chris. Barry.
Thank you, Chair. I seem to have lost my video. I don't know if you can see me, but I can't see anybody else. But thank you for the presentation, Mark. Some years ago, I can't quite recall how many, there was an instruction for ambulance staff to bypass the George Eliot Hospital and take patients straight to UHCW. And I'm wondering if that's still in force. And I don't know if it's in force in the South Warwickshire area as well, but that would go to some way towards explaining why George Eliot and South Warwickshire seem to be handling cases better than UHCW, which seems to have a big traffic jam sometimes with patients. So I don't know if you can confirm if that's still a policy or whether it's now been removed and the ambulance staff can take people to George Eliot and South Warwickshire.
Okay, Barry, thank you for that. I can't see your video, so I'll imagine what you look like if. There's never been a formal policy of bypassing any hospital. The instructions to staff is to go to the nearest appropriate hospital. Now, what you find for hospitals like the George Eliot, and I can say this because I was a general manager there for 4 years, some of the district general hospitals don't offer the whole range of services that you need. So, for example, they can sometimes struggle to look after very sick children. So we may have agreed protocols or pathways where for certain conditions we might bypass the hospital. Not that the hospital can't cope with things, but maybe just because the infrastructure is not there. So for children, for people with hyperacute stroke and for heart attacks and for major trauma, we wouldn't tend to go into a district general hospital for conditions like that. Obviously, we deal with 22 emergency departments across our region, so we can't give you an exact answer for the whole of the region, but I can speak for the George Eliot. So we would try not to take very sick children into the George Eliot. That's absolutely true. We try not to take stroke patients because it's not a hyperacute stroke unit, and we wouldn't take heart attacks or major trauma. But the George Eliot's a good hospital for what it delivers. You know, as we've seen, we don't get delayed handing the patient over. People get a very quick response. And I have to say, I know a number of the consultants there. I'd be very, in actual fact, so I'd be very happy to use it. I do use it. It's my local hospital if ever I become unwell. But that sort of illustrates the other point, is that one of the things the ambulance crews would take into account is how quickly you can get somewhere. So although the George Eliot might be nearer, by the time you've fought through the traffic, you might be at UHCW quicker. So depending where the crew have come from, they might go to a. So as an example, if I get a crew that are a Coventry crew, they may be more tempted to go to UHCW because they're ready for the next job, if you see what I mean. So it's nothing other than that. It's the logistics of how we provide a service. That's all it is.
Right, thank you. David's just put on that George Eliot doesn't have inpatient facilities for children. That's another change that I didn't know about because it did have up to 16 hours to take children. So it goes on, doesn't it? So, okay, I have to live with that. But as far as I was concerned, or as far as I was aware, because I was quite assured that there's a definite instruction to ambulance staff to bypass the George Eliot in almost every case. I understand you being a bit more picky about which ones to go, but that comes down to the ambulance staff having to make a judgment decision, and I'm not quite sure that's fair. They don't have the specialist training to make such decisions like that. So there's a whole raft of things that could be going wrong with this, but at the end of the day, it is what it is, isn't it? So thank you very much.
No, Barry, just to clarify there, the staff would take the patient into the George Eliot as the nearest hospital unless there's a specific agreed exception to that. And I know when I'm out with the crews, we often go into the George Eliot, you know, because that's the nearest hospital. And, you know, for many patients, Nuneaton, Bedworth, Wolvie, you know, the George Eliot will continue to be their nearest emergency department, and most people would go there. I think, Chair, you might be on mute.
Thank you very much for that. I've got one more speaker, Pam. You're on mute, Pam.
Sorry. The problem with the handover to hospitals is not something that has just occurred because of COVID. It's an ongoing problem. Have you spoken? Have you a procedure? Have you had discussions with how this protocol can be improved? I mean, if it's improved, then we will get a better response time across the county.
Yes, you're absolutely right, Councillor Redford. I think this is something. So I've joined a national group looking at this, and this is something I remind them every month. This is not because of COVID. We had handover delays pre-COVID.
Yeah.
COVID has made it a little bit worse. That's all, just a little bit worse. But what COVID has done is, so this isn't happening in Warwickshire, but this is happening in other areas where yesterday, for example, we had 168 patients during the day who were delayed in the back of ambulances. And that's a big concern. So if you take, at its worst, an elderly lady in the back of an ambulance for over 7 hours. So I don't know what temperature it was last night, but recently it's been -5. The ambulances don't have heating. They have heat generated from the engine. So if we want heating in the back of the ambulance, we need to keep the engine running. If we want ventilation, we need to keep the ventilation running. If you're in a static environment with the engine running and the ventilation going, you're not going to be in a great place, because the ambulances are designed to be moving, and when they're not moving, to have the engines turned off. The other thing is, we had an elderly lady that needed the toilet twice in the back of the ambulance. There's no running water, there's no toilet facilities, there's no facilities for getting a cup of tea or coffee. They're basically vans designed to transport people. They're not designed for looking after people long term. Now, what we believe in all of this, and I think we've been in front of the Warwickshire hospital before, it's leadership and grip. It's leadership and grip. So it's no coincidence that the George Eliot doesn't have handover delay problems. That's because David takes leadership and grip very seriously. As does Glenn Burley down at Warwick, as does Andy Hardy, in fairness. Andy takes it very seriously. Unfortunately, in some areas, it's not top of their priority to sort out, therefore it's allowed to happen. And as you've rightly, if we have an ambulance delayed for 7 hours, that's an ambulance for 7 hours that cannot respond to any patients. So will patients suffer? Of course they'll suffer, because they'll have a delayed response. And in an emergency service, a delayed response isn't a great thing. So, we're really working hard. I mean, I'm hated across some parts of the region because I keep writing to chief execs telling them how unacceptable it is outside the hospital. But, we won't give up until we don't have a problem. Now, in fairness, everybody's entitled to a bad day. We all have a bad day in our services, so we're not asking hospitals to be perfect. What we're asking them to do is just, so what they'll say to me is they can't cope with the number of patients because their department's too small. Well, I told them the department was too small 5 years ago and they haven't done anything about it. So you can keep walking into a disaster, or you can do something about it, can't you? And I think we do need to make sure that hospitals keep improving, because we're not seeing improvement with handover delays across the rest of our region. George Eliot would never have problems for years. Warwick Hospital, I can't remember any year where we've had a problem, and yet Warwick Hospital isn't massive. The ED hasn't been extended for years. It's a busy hospital. So if they can do it, then other hospitals can. And the other thing in all of this, we mustn't assume that because Warwickshire's okay, because if Birmingham's not okay, they're going to take some of your resource to compensate for their delays. So it affects everybody if there's delays anywhere.
Thank you very much. I've got one more question, then we'll do it to close. Mike Bain. Mike.
Mark, I think it's good afternoon now. We've gone on a little while. Thank you for your excellent presentation, a very professional presentation. You know your business without a doubt. I'm an ex-ambulance man from 51 years ago, when it was quite different. I think my training was a 10-week Miller certificate training at Birmingham Central Fire Station, and that's all we had. And I was a frontline ambulance man for a number of years before I joined the police force. My question is really, I live on the border of Gloucestershire, which is Hereford and Worcestershire, and we're a growing community, circa 5,000 houses on a new green village. And my question is, what provision will be put in place for the call-out times to this location? What cross-cooperation is there in with Hereford and Worcestershire at present time? It's a concern because I know where I live, I see at least 2 ambulances a day go to Meehan Vale. I don't know if you know Meehan Vale, it's the new village and the airfield as well. So it's quite critical, the timing. That's the sort of question I'm asking. What cross-cooperation?
I mean, it is a really good question. I think before I answer the question, I do want to say that the presentation I've done was put together by Pippa. I've only spoken the words, so to give Pippa a lot of credit for actually putting.
Well done, Pippa.
We're a good team, yeah, it's a really valid question because, like you, I live on the borders of 2 ambulance services. You know, where you feel caught in the middle almost. Yeah. I live literally just the other side of the A5 to Nuneaton, so I'm officially in East Midlands, even though I feel like I'm more in West Midlands. So I think the important thing from our point of view, by way of delivery of an ambulance service, is we moved away from the concept of an ambulance station model many years ago. So we no longer have the idea that you've got a Hereford and Worcestershire ambulance service or a Warwickshire ambulance service or a Coventry ambulance service. So people will remember, for example, when we had an ambulance station at the George Eliot Hospital, and we've moved away from that. So we have the ambulances in North Warwickshire, for example, are covered by Longford ambulance station. They come out there during the day. Down in the south of the county, we still do have an ambulance hub at Warwick, and we have one at Hereford and that. But the concept of the hub model that we've got is the ambulances really only belong there when they're being cleaned and restocked. Other than that, they're never there. They're out and about. So we see the ambulance as a mobile resource that only literally goes back to the ambulance station for what we make ready. That's when they strip it down, clean it, restock it, and then it's out the doors again, never to be seen until it's ready to be restocked. And during that shift, it can go. So it's not a fixed asset. So, for example, I was down a shift recently with a crew that are based in Craven, which is Shropshire. And during that time, we travelled over 300 miles during a 12-hour shift. And we never went back to Craven Arms, you know, and much like a crew from Longford will never go back to Longford during the day, unless it's maybe for a quick cup of coffee. But, you know, they'll be out and about. And actually the ambulances go where the demand is. So if there's more demand in South Warwickshire, more of the ambulances will drift down to South Warwickshire to deal with that demand. Equally, if the demand happens to go up to sort of, I don't know, Bedworth, then the ambulances will drift into that area. So it's not a fixed model. What we then do is every year we establish, more than every year, we'll establish the resourcing that we need. So by way of how many ambulances on a shift and how many staff. So just yesterday we were having a discussion about taking on 160 extra staff to cope with the demand that we see coming forward, and then to increase our sort of ambulance provision by way of the vehicles. So all the time we're looking at the totality of the resource, but we don't fix it to a location as such. As far as mutual aid goes, that's a little bit more difficult. Obviously, Hereford and Worcestershire is our own patch, so it's not mutual aid, it's just what is expected. But if you go down to, say, somewhere like Gloucestershire, we would go into Gloucestershire to help them more than they would come into our area to help us. And that's the case of every ambulance service that surrounds us, be it the Northwest, the East Midlands, Wales, southwest, I think maybe east of England on a little patch of it. But most ambulance services that we border, we would help them more than they help us. You know, we're constantly reviewing it, and it is difficult, particularly for the rural areas. You've just got to look at the distance between some of these villages, and it's hard to work out where you need to put the next ambulance to get to the next job, because of course you don't know where the next job is going to be. So if you're somewhere like Coventry, you can almost guarantee that you've got an ambulance within 10 minutes of the patient wherever the ambulance is in Coventry. In some of these smaller villages, it gets much more difficult to do that predicted work.
Yeah, I know at some time you position an ambulance, say, halfway between Warwick and Stratford, so it can go either way. I've seen them sitting in the lay-by waiting for a call, which isn't always good, but I understand the reasoning behind it. Just one further question. You mentioned helicopter support. I assume these are helicopter support which has no support financially from the government.
Well, that's not strictly true, because the helicopters themselves are run by the charities, and the pilots and the fuel and the airbase is run by the charities. There's a collaborative approach to providing the clinical staff. So for the Midlands Air Ambulance, which covers 3 of the 5 helicopters, we provide the clinical staff, including the doctors, the paramedics, the critical care paramedics. For the Coventry, or it's the Warwickshire and Northamptonshire Air Ambulance that's based at Coventry Airport, they're a completely standalone charity, so they employ their own paramedics and doctors, but we deploy the helicopter for that scenario. So we're working very much hand in glove with them. We've got more helicopters in the West Midlands than any other part of the UK. So to have access to 5 helicopters is quite something. There is an advantage with them being independent. If you talk to the charities, I work very, very closely with them, and on occasions I work on the air ambulance from Cosford. The charities are quite upfront. You know, the great advantage with being independent, they generate their own money and they do what they want to do, so they're not confined by government targets and other priorities, and that gives them a lot of freedom. So as an example of that, in the West Midlands, the Midlands Air Ambulance are putting on a trial using blood of helicopters, and if that was part of an NHS resource, it would take a lot longer, or you would have the resource and the ability to do that. So they're able to push things out because they're a charity. So under our governance, we have a lot of control over what they do and how they do it. So my view is it works really, really well.
Thank you, Mark. The only thing I would say in relation to that is they're struggling because their charity shops are closed, or some of them are closed at the moment. So the funding source is not as good as it was pre-COVID.
You're absolutely right.
Thank you.
Okay, Mark, Pippa, thank you very much for your presentation today. It certainly has covered, I think, all the aspects of the ambulance service, and we're very pleased to hear and see that Warwickshire appears to be, in particular in our hospitals, handling your patients better than anybody else. So that is good news. Would you please pass on to all your staff our appreciation of the work they do, because we know how difficult it is under the present circumstances, and we really do appreciate the work that they're carrying out under those difficult circumstances. So thank you both very much for joining us today, and hopefully we will see you soon. Thank you very much.
Thank you very much
for your time.
Thank you.
Okay, our next item is item 7, and it's Sade for an update on COVID.
Yeah, so I was just trying to put on my camera and my video back. Right, so I'll run quickly the update, conscious of time. Nationally, the EPI is all going in the right direction. The West Midlands is doing a lot of testing, so a lot of PCR testing, which means that our case numbers will be higher. We're also doing a lot of lateral flow testing. The case rate of the West Midlands today is 195 per 100,000. We are the highest in the country, but it's come down from 218. The England case rate is 148 per 100,000. The lowest case rates are in the southwest at 99.8 per 100,000. Across the West Midlands, Sandwell and Walsall are seeing the highest in case rates. Sandwell is 309, Walsall is 296. Herefordshire, some of the lowest case rates are 73 per 100,000. The EPI shows that lockdown is working, but it's working really slowly because it's different to the first lockdown, because as we all know, more businesses are open. In terms of the local picture, our rates are the second lowest in the region. So Warwickshire's rate is 143 per 100,000. The rates have come down quite nicely across the board. So across all our districts and boroughs, rates have come down. All our over 60s rates are also coming down. So Stratford has got the lowest rate at 87 per 100,000, North Warwickshire at 197, but that is also on a downward trend now. Positivity has also come down nicely as well, with Stratford having one of the lowest positivities across the West Midlands at 4.8%. I'll briefly talk about testing. Our lateral flow testing, as you're aware, we've got 6 test sites that are operating at near full capacity on a daily basis. We have in total conducted over 70,000 tests. Positive tests as a result of that test is nearly 700. I've previously described some of the information that people get when they want to book for a test. We are now working with our workplaces across the county to put in place workplace offers. So 3 business settings have workplace offers in place. We have another 4 to 8 businesses that are in the process of setting up self-led testing in the next week. I'm not sure if people are aware, but there's a national business offer as well that is now being targeted at businesses of more than 50 employees. But we continue to support all of our businesses in the meantime. So the offer is currently open, and we've written out to all businesses who need that support. Indeed, some businesses have visited some of our community testing sites to shadow and to see how community testing, lateral flow testing is done. In terms of outbreaks, we are potentially now starting to see a decline in outbreaks in workplace settings, and it's now starting to settle as well in care settings. But what we're seeing is once the virus gets into those settings, it remains very difficult to control. And we've seen a number of office-based outbreaks with very high attack rates. The team have developed a presentation for employers to support them to train their managers and their teams to ensure effective workplace contact tracing, because we've identified that this remains a weak point with some employers. They really do not understand the process of contact tracing and what they need to do and who is identified as a contact and who is not. We remain very cautious in our approach and continue to recommend that settings go above and beyond national guidance where they are able to control the virus, given the ease with which the newer UK variant is spreading. We continue to work with our districts and fire service to support door knocking where necessary. Just a little bit about the variants of concern. We are now thinking through how we manage new variants as we go forward. People are probably aware of surge testing, which was named Operation Eagle, which was started across 9 different local authorities to look for the South African variant. The surge testing program has now been extended to look for the Brazilian variant as well, and is now extending to other variants. There's recognition that there are quite a number of variants. There are some variants that are termed variants under investigation. There's variants of concern, but the process of searching for them is the same. The Kent variant, the UK variant is now the predominant variant across the UK. It is much more transmissible, as we already know. So the biggest worry that we have now is that the Kent variant will mutate. In our region, Walsall, Birmingham and Worcestershire have been involved in Operation Eagle. Walsall has finished the first round of testing, of surge testing, but no variants have so far been identified. Birmingham finishes their own program of surge testing today, and no variant has been found similar to Walsall. the variants that have been found to date have been found through surveillance and from taking a proportion of samples from all samples and sequencing them. For us in Warwickshire, there's no variant that's been identified. None of the new variants have been identified within our county. But what we've done is to try and start to put in place a process where once we are told, if we're told, I'm hoping that we will not be told that we've got a new variant in the county, but we've started to put in place a plan where any plans for surge testing will be led by our IMTs, our incident management team meetings. So we've prepared some comms material ready to go. We've identified an incident manager from Fire and Rescue who will take a lead role. We've started to work with our mobile testing units to ensure that we will designate any area that needs to have increased PCR testing. So we're doing all of that planning in the background to prepare for emergence of a variant of concern within the county. I'll stop there now. Thank you, Chair.
Thank you very much, Sade. Any members have any questions for Sade? Keith.
Thank you very much. The news sounds a lot better at the moment, but obviously things come back and bite us. One of the big saviours is going to be the vaccine. If it obviously doesn't have a variant that it doesn't work with. Have we got any early indications that vaccines are helping yet? Or because I have a fear, and I've been talking to lots of people who have been vaccinated, that some people aren't being told when they're vaccinated to be careful for the next 3 weeks. Some GPs and places are saying, this doesn't make you bulletproof. You have to be careful. You have to follow all the rules. Whereas others seem to be like, here's your jab and go back out after 15 minutes. And I see from the Israeli data that actually a lot of cases actually come in the 8 days after people are vaccinated, because they're so happy about being vaccinated that they let their guard down. So have we got any feeling of A, our vaccinations actually turning our figures down, and B, that we're actually making sure people get the right messages about being careful, because it will take a while for the vaccine to give you even 50% protection? Thank you.
There's some cautious feeling nationally that vaccinations might be having an impact on the decline in numbers that we are seeing. The actual evidence to support that is probably not yet available. In terms of GP behavior and information following vaccination, that is probably an issue for quality assurance and consistency in the messaging. People should be told after they receive the vaccine that is no license to change their behavior, and that is the ideal messaging. So if some GPs are not doing that, then that's probably something for CCG colleagues to pick up and reinforce the messaging, that people should be told that after vaccination you still need to behave as if we are living in a pandemic, and you can't still transmit the virus even though you've received the vaccination.
If I might just come back, I say it's not consistent. Some are doing really good, and it's also the other centres, the CP, Coventry Warwickshire Partnership. The messages aren't always the same for everyone getting vaccines, so it'd be nice if the County Council Health put out that message as well.
Thank you. Alison, did you want to come in at all?
I will. I'm happy to that you're right. That is the message, that it doesn't stop you actually getting COVID or therefore transmitting COVID. It just should reduce how ill you get with COVID. So I will reiterate that message to all the sites, all 27 sites we've got.
Thank you very much. Barry.
Thank you, Chair. I think I've got my video back now.
We have got you, yes.
Yes. Thank you for that, Sade. Can I don't want to misquote you, heaven forbid, but could you just qualify that, or just tell me again that we haven't found any variants in Warwickshire? I'm not aware of any surge testing that's been going on, so how would we know that in Warwickshire that we haven't got one of the variants? Or do we wait until one pops up and then do the surge testing? I'm not quite sure about the process.
So the process is one of which samples are regularly taken randomly for testing. So every single test sample for PCR testing. There's a random sample that is taken from each local authority, and they're subjected to additional sequencing to identify whether or not the sample is whatever variant there is. And to date, none of the random samples that have been sequenced across Warwickshire have yielded that information that one of them is the variant of concern.
Thank you for that clarification. That's very good news. In terms of the injections, I've had mine, and there's a very jolly nurse or a volunteer, I'm not quite sure what she was, but she did stress the fact that it's no way can we say that we're not going to be infected with it. We can still get it even with after the injection. More chance of not getting it after the second one, whenever that's going to be, I'm not quite sure. And if we do get it, the idea will be that we won't get it as badly as a lot. Because I mean, I'm one of those people that if I get it, I've had it. I'm for the oven. So that's about the best I can come up with. But that's that message was being put out very clearly at the testing station in the Neaton. The inoculation centre in the Neaton in Heron Way. So it's and as far as I can make out, the people I've spoken to have had it. They're all on message, and it's not just a thing about getting it yourself. It's about not being selfish and giving it to other people because you can't carry it, even if you don't get it yourself. And I think that's a very clear message that's gone out. I'm not quite sure where Keith's getting his information from, but my information is completely the opposite way. People are on message and they are doing what they're told. Thank you.
Thank you very much. Helen.
Thanks, Chair. Yeah, I just wondered in relation to the success of the vaccine, is that only being monitored nationally, Sade, or how are we feeding into that?
That's being monitored nationally at the moment. It's still probably too early to tell on a local basis.
We must be feeding in, I suppose.
Absolutely, yeah. So the national numbers are being used to determine whether or not there is an impact on transmission. In terms of whether or not vaccination is entirely responsible for the declining numbers that we are seeing in Warwickshire, there is no data to suggest that. I would like to think it's probably a combination of all sorts. So combination of vaccination, combination of the lots of testing that we're doing, both PCR testing and lateral flow testing, and combination of people doing the right thing. But in order to disaggregate it and determine exactly what is responsible for the decline in numbers locally, that work is not being done.
Okay, thanks.
Thank you very much. Thank you for Sade, and for your contribution too, Alison. Thank you very much. I'm very conscious of the time, and we still have an important item to deal with. Going on to item 8, the update on the scrutiny review carried out by Dr. Jane Martin. Nicola, did you wish to lead on this?
I can do, Chair. Thank you. And thank you to the committee for sort of adding the item. I'm conscious of the time, so I'll keep it very high level because the most important thing is the views of the committee and members on what they think about the report and sort of the options. So as members will know, pre-COVID, which was a long time ago, in February 2020, we commissioned Dr. Jane Martin, CBE, to give us some assistance in how we might improve on our current ways of operating scrutiny and develop the approach to deliver on the council plan and objectives. The feedback was very positive and highlighted some examples of good practice and was particularly complimentary about this committee's sort of approach to training its members and making sure that people were up to date on the items that they were considering. But it did identify some opportunities to improve and some principles around which we might structure a refreshed approach. I've set those out in paragraphs 2 and 3 of the report, but the key thing really, I think, is the recommendations that came out of the review and the questions that I'd like to put to the committee. So there was a view that a relaunch of the scrutiny function, highlighting a sort of collegiate, constructive, challenging behaviour code was an option, and that there may be ways of creating greater alignment with corporate objectives. And obviously, from feedback from members who were interviewed by Dr. Martin, a desire to see a greater use of virtual meetings where appropriate, and ways of engaging with the public, service providers and external partners in moving scrutiny forward. There were some practical suggestions, as you can see in paragraph 5, around reviewing timetabling of meetings and trying to optimise them within the cycle of other agenda items going on within the council. And at section 5, I'd set out some questions which are intended really just to help the consideration of the committee as we move forward, around whether the council and members of the committees actually do wish to consider reconfiguring the scrutiny committees, and if so, how that might look, how the committee feels agendas might be reinvigorated to sort of promote scrutiny, what are the members' views on the opportunities and principles that Dr. Martin recommended in the report, and how would members like to see sort of technology used to improve these things, and training around bespoke training plans for all scrutiny members, sort of not just sort of generalised training as part of the member development programme. Appreciate that's a bit of a whistle-stop tour of my report, but I know you're short on time, so I would was going to suggest that members obviously may want to comment on those things now, but if people have anything they think of outside of the meeting, if they feed it back via Paul, then he will get those comments to me as well, because the proposal is that I will work with Dem Services to produce a proposal for the future of scrutiny, which we will bring back kind of post-election to members to comment and consider. So if anybody thinks of anything post this meeting, please do feel free to send it through.
Yeah, thank you, Nicola. I was actually going to suggest to members, because of the time constraint that we now have, that they consider the report with a little bit of leisure and forward their comments to Paul, and Paul and I will get them together and make a formal response. We do still have a little bit of time, so Margaret.
Thank you very much, Chairman. I just wanted to say how much I welcome this report. I think it's really good. It's concise, it's insightful, it's got some really strong recommendations and some good questions, and I think it's excellent. I think to me, it touches on one of the things that I've been slightly concerned about, and that is internal scrutiny. I think in this committee, we're very, very good at external scrutiny. We pick up things that are going on in the environment, as we've done today, and we really give them a good questioning, and it's very useful. But what we tend not to do is to link in with what's going on in Cabinet and any decisions they're making. So just as an example, under agenda item 9 on page 35, there are 2 Cabinet portfolio holder decisions there. And it may be that maybe they weren't relevant, but they haven't been to this committee before those decisions were made. We haven't had the opportunity to feed anything in a supportive way, but have you thought of this, it might do that, etc., etc. And surely that is part of scrutiny and something that I would really welcome. And obviously we may not be able to look at all decisions of Cabinet, but there are some that are really important that ought to come here in a timely way, and that is a critical issue. What's the timely way? How far in advance do we know, and can we dovetail the meetings accordingly? So that, to me, that was really, really good insight into something that might improve things, and I think it's an exciting opportunity to have a rethink, build on what's good, and there's lots that's good, build on what's good, but improve the way scrutiny works. Thank you.
Yeah, thank you, Margaret. I think you've made some good points there. Clive.
Thanks, Chair. I just want to refer to on the recommendations, recommendation number 2, which suggests the creation of a sort of super panel comprising all the scrutiny chairs. I'm just a bit dubious about this because I don't really see, and incidentally, I think it's kind of modelled on the House of Commons liaison committee, isn't it? But I mean, you know, it may have a different function to what it might have in a county council. But you know, I just can't quite see at the moment how that would make scrutiny overall more efficacious, as it were.
Did you want to come in on that, Nicola?
If I can, I think the idea behind it was that it would allow chairs to consider items that might cross across committees and find a sort of efficient way of dealing with those items, whether that might be through something like a member working group, as we had with the COVID items that crossed the boundaries of committees, and to look at those items sort of in a single way rather than lots of different committees looking at them and then feeding into the same thing. So I think it's more of a capturing of things and making sure that they're dealt with sort of once rather than several times.
Okay, thank you. Chair, I have to leave now.
Okay, Clive, thank you very much indeed for your contribution.
My substitution, yeah. Okay,
thank you. Yeah, Nicola, just on that particular point, I mean, we do have, I mean, the adult social care has joint meetings with the children's committee, so it's not something that we don't actually do. I mean, I think we would be stretching it a bit to expect that all committees have something that is appertaining to another committee and so on. So I do have some reservations about the need for another, if you like, another chairs committee. I would like to see some evidence, you know, some evidence that that type of committee would actually improve what we are currently doing, because we are now having quite, I say, regular joint meetings with with the children's young persons committee, which is very useful on the, you know, because we do have a crossover.
Yes.
So anyway, Jerry.
Thank you, Mr. Chairman. Just a couple of things. Of course, the chairs used to always meet some years ago, a long time ago, but perhaps the terms of reference for the chairman's role should incorporate about cross-working and talking, as Wally said. I think Wallace has said in relation to that, rather than, like you say, creating another committee, actually make it in the job description of the chairman, which I think probably needs to be revisited in light of these as well. A couple of other points, really. Capacity from the Democratic Services side, to a certain extent, whether it's a Democratic Services officer or a scrutiny officer, you just haven't got the capacity to do the job properly. And therefore, unless that capacity is increased, you know, it will be back here or people will be back here in 4 or 5 years' time, grumbling about bits and pieces. So I think that does need to be done. And I'm more than happy with the Democratic Services officer that's allocated rather than trying to split roles. I've worked under both. I do think that we need to follow corporate priorities or what's happening. So I do think that the realignment of scrutiny and scrutiny functions needs to be done, and bring everything into closer alignment. And there needs to be something around how the work programme and working with partners and calling for scrutiny programmes is done. So there's a more public front-facing position. And I suppose lastly for now would be the bit around the higher profile for scrutiny on the County Council website. If you go on there and try and find a task and finish group, for instance, can you help me as a member of the public? I can't find out you know, what you're doing. I know who's on the committee and I can see the public agendas, but can I find out what you're doing? I haven't got a clue. And so I think, and I've mentioned this to Rob Powell, I think it's extremely poor. So that's an area which I think could be ramped up much higher to actually give it greater public profile. And of course, last point really, in relation to health overview and scrutiny, it has statutory duties to do. So you have to have a health overview and scrutiny committee to deal with that, which of course some of the others don't, which is why it's probably a different style because of the way that it has to work with partners and deliver that. But I do think the Health and Wellbeing Board, who holds that to account, and I'll leave it there.
Thank you. John.
Yes, thank you, Chairman. I welcome this report also because I've got to be honest with you, scrutiny has never been something I've been particularly good at, either at the County Council or at the District Council. So I welcome this, and it does go into quite a lot of detail about things. Having said that, you know what a miserable devil I am. I just, yeah, well, that's right. Well, on page 16, which is paragraph 2.1, the fourth bullet point down, it says work smarter. Meetings should be more flexible, proactive and responsive to corporate priorities, which is something Jerry's just mentioned. Yeah. Meetings should be collegiate, constructive and challenging. Now, I have to tell you, I could do with some examples of how you would do some of these things, because I'm not at all sure what this actual paragraph means, other than the bit relating to corporate priorities. So, Nicola, let me know.
Do you want to come back, Nicola?
Yes, I think the point is about sort of the sort of perception in some quarters, not necessarily here, but if you read sort of national views on scrutiny, that it can be seen as sort of a telling off almost, or something that's there to sort of push at people, and that actually you can have better scrutiny and sort of come to better conclusions if people work together in a sort of can-do, I think is what the paragraph is trying to get to. A positive attitude, absolutely. If I could quickly pick up on something that Councillor Redford mentioned around the statutory requirements as well of committees. That is one of the things that we sort of governance and policy have been considering and feeding back, because yes, there are, there's this temptation to say, you align your committees exactly to your corporate plan, but you have got to make sure, that as a council we are picking up on all of the statutory functions that we actually have to fulfil as well. So that will be fed into, along with all of your comments, the plan that we come up with to move this forward.
Yeah, thank you. Well, I think, Nicola, from the comments that you've had from us this morning, that we are responsive and welcome this report. What I am going to do is ask all members of the committee if they have any issues, any points that they wish to incorporate into a committee response, because that actually is what is required. It's a response from this committee on this particular paper. So I shall get Paul to send out a note to all members to ask them to put their responses forward, and then we will collate it together and send a committee response on the issues that. Now, I think you're seeing the other committees this month and March, so I'm probably going to give our members about 2 weeks to respond and then pull something together. Will that fit in?
That would work lovely. Yes, that would be great. Thank you, Chair, and it will be very helpful to have a sort of consolidated view from the committee.
Yes.
As you say, I'm going to see. I'm at communities this afternoon, and then I'm sort of feeding into resources and children's within this cycle. And the proposal was to sort of come back with the initial proposal to members in some form, sort of post-elections. So that's absolutely fine in terms of timescale.
Yeah, that's fine. We'll take that on board. I have to say, I've read the report 3 times now. and I've got scribble marks all over it. But having said that, I think it's an excellent document, and it really does, I think, bring home what scrutiny needs to be looking at and what it's all about. I think we have lost our way. You know, yes, this committee, as you've highlighted, has done some good thing, and that is shown in the report. But I really do think, in general, thinking about what scrutiny is all about, it is the word is there, scrutiny. We're there to scrutinise the work of the county, in particular the work of the county council, as it refers to our committee. So I welcome it, and I hope that Cabinet and the corporate board will take heed of this report and the comments we make. So thank you very much for coming along. Thank you.
Thank you for having me, Chair.
Thank you. Okay, moving quickly on. We've got the work programme. Have we got any comments on the work programme? I'm very conscious of time. I know I've overrun and broke my own rules in numbers on the agenda, etc. But we did need to pick up the speed on some issues because we were getting a little bit behind. So anybody got any comments on the work programme? Margaret?
Thank you very much, Chair. Very briefly, I just feel that we had a good presentation on the HEART project, and they're on an improvement path, and it would be really good to keep track of how that's going at some point, whenever that's appropriate. Thank you.
I've already got it marked down, Margaret, for a briefing paper to come out to members. Are there any other points quickly on the work programme? And Sally, yes.
Yeah, sorry, just a quick question. We haven't got any dates for the next meeting. Well, sorry, there is a date for the next meeting, but you haven't got anything itemised that's going to be covered. Is that going to be decided between now and the next meeting, please?
We will have a spokesperson's meetings to firm that up, Sally, yes.
Okay.
And it will. You will get due notice, of course, yes.
Okay. Thank you.
Anything else, anybody? Okay, well, thank you all very much for your contributions and your patience, but I think we've had some good contributions this morning from our partners, shall I say, and look forward to speaking to you again. Thank you very much indeed. Thank you.